my colleague, Dr. Ahmed Boushehri. He is the head of the Unit C at the Department of Radiation Oncology in Kuwait Cancer Control Center. His responsibility is head and neck cancer, lung cancer, thyroid cancer. He pursued residency training program in and fellowship in radiation oncology at University of Toronto. Dr. Ahmed, welcome, and stage is yours.
Masakum Allah bil khair. Good afternoon, everyone. It's my pleasure to be amongst all of you today, my friends and colleagues, and thank you for the invitation. So, in the next 10 minutes, I'll be talking about this NRG trial that looked into concurrent chemoradiation plus minus atezolizumab, a limited stage small cell lung cancer by Kristen Higgins. These are the disclosures for the study. So, we know that long-term survival for limited stage small cell lung cancer is about 30% at 5 years, with a standard chemoradiation plus minus PCI. The recent successes with the addition of immuno to chemotherapy has improved survival in extensive stage small lung cancer. We have to make sure this is in non-curative settings. So this NRG trial looked into adding atezo in the concurrent chemoradiation in limited stage small cell lung cancer. So this is the schema of the trial. This is a phase 3 trial done in the US and Japan. It's about, they enrolled 544 patients with inclusion criteria as limited stage, small cell lung cancer, performance status 0 to 2. And these are the stratification factors: radiation schedule, either twice daily versus daily, platinum, cisplatin versus carboplatin, male versus female, and ECOG status 0, 1 versus 2. So prior to the randomization, they receive one pre-registration cycles of chemotherapy, and then they are randomized into chemotherapy every 3 weeks for 3 cycles, plus thoracic radiation, 45 gray BID or 66 gray daily. This is the standard arm, and the other arm is just adding atezo every 3 weeks up to 17 cycles, or when there is any progression or unacceptable toxicity. So the primary endpoint for this study is to compare overall survival for patients with limited stage small cell lung cancer treated with the concurrent chemoradiation plus minus atezo. Secondary objectives is progression-free survival, overall response rate, local control, distant metastasis-free survival, and also they looked into to characterize the immune-mediated and non-immune-mediated toxicity from chemoradiotherapy plus atezo, and also to determine the association between small cell lung cancer molecular subtypes with the clinical outcomes. So the primary hypothesis, what they came up with, is that the concurrent chemoradiation plus atezo will improve median overall survival from 27 to 38 months with a hazard ratio 0.71. The 85% power to detect a hazard ratio of 0.71 at one-sided significance level of 0.025, and the overall survival defined as the time from randomization to death due to any cause, but the primary analysis will be performed on an intent to treat basis. So this slide just showing the interim analysis. It was done first, second, and then final. I'll go through this in details. I'll move into the results just for the sake of time. So 506 patients acquired from May 2019 to June 2022. But then Japan continued until December 2023. So it was 500 patients from US and 44 patients in Japan. And 218 institutions were included with a median follow-up of the patient for up to 21 months. So this is the baseline characteristics, and it is well balanced between both groups. But we can notice here that the majority of patients are 60 years old and above, with the ECOG status 0 to 1, and the majority of patients smoked at some point in their life. And again here, in terms of stage, chemo, radiation schedule, PCI, it is well balanced between both treatment arms. So radiation therapy, QA, IMRT, and 3D conformal allowed. 92.8 received IMRT in the control arm and 91.3 in the atezo arm. Robust radiation QA program. First 3 cases reviewed before treatment for each center. 97% had radiation acceptable or variation acceptable plans in both arms. The primary endpoint is overall survival. So you can tell here the blue line is the concurrent chemoradiation, and the red line is the concurrent chemoradiation plus atezo. Surprisingly, that the median overall survival for the chemoradiation for the concurrent chemoradiation arm is at 39 months compared to 33 months in the atezo arm. So the hazard ratio is 1.1 and 95% confidence interval crossing 1 with a p-value of 0.7. So there is no significant overall survival benefit of adding atezo to concurrent chemoradiation. Again, for the progression-free survival, no difference at all, and it showed with a hazard ratio of 1. And in terms of distant metastasis-free survival, they're saying there is a trend towards improvement with adding atezo, but again, this is not statistically significant. Similarly, for the time to local failure, it is no difference between both treatment arms and no benefit of adding atezo as well. So overall survival from patient subsets, so they looked at the different subgroups, and you can see that the hazard ratio hover around 1. So there is no much difference between the different subgroups. And again here, in terms of progression-free survival, the hazard ratio centered around 1 and no much difference between the groups. What was interesting for them in the study is looking into the fractionation. This is one looking to radiation fractionation either twice daily versus once daily. So they're saying that the patient who received twice daily, there is a trend towards longer survival compared to the patient who received once daily 66 gray. But this is not powered and not adjusted for this study. But then they put all the patient together. So it was unadjusted overall survival. And you can tell that the overall survival for the patient who received it twice daily is about 30, if I remember the numbers, 35 months compared to 28 months for the patient who received once daily radiation. So in terms of safety, there is no safety signals in both arms, or mainly in adding atezo to concurrent chemoradiation, and we can tell that the any grade adverse event is 99, almost like the same in both arms, and also and you can tell that the immune-related adverse event is higher when you add atezo to concurrent chemoradiation. In terms of compliance with treatment, number of atezo doses, the median number is 8. The patient was able to receive up to 8 number of atezo doses. And the reason for discontinuation is mainly due to disease progression. And again, completion of radiation, completion of chemo is similar in both arms. Pneumonitis, as expected, it is slightly higher in the atezo arm and a grade 3 plus toxicity. Pneumonitis is 4.9 compared to 3.2 in the concurrent chemoradiation arm. So just to conclude this study is that the concurrent atezo did not improve survival for patients with limited stage small cell lung cancer compared to standard chemoradiation. Twice daily may be associated with improved survival compared to daily radiation and could be considered the optimal choice for radiation fractionation. Additional analysis is warranted. Thank you.
Thank you very much, Dr. Ahmed. We're going to keep the questions to the end of the session. Uh, our next Our next speaker is Dr. Fahad Arwais, a radiation oncologist from King Fahd Specialist Hospital, Dammam, Canadian and American board certified radiation oncologist. He pursued residency at McGill University and fellowship in radiation oncology at Stanford. He's going to present the safety profile of durvalumab as consolidation treatment in limited stage small cell lung cancer in Adriatic, focus on pneumonitis and immune mediated adverse events.
Assalamu alaikum. Good afternoon, and thank you for the kind introduction. So in the phase 3 Adriatic study, durvalumab consolidation treatment significantly improved the dual primary endpoint of overall as well as progression-free survival compared to placebo for patients with limited stage small cell lung cancer. Durvalumab consolidation treatment for up to 2 years was well tolerated, with safety finding consistent with the known profile of durvalumab monotherapy in the post chemoradiation setting. Pneumonitis and radiation pneumonitis analyzed as a group term is a common adverse event and was observed in both arms. The immune-mediated adverse event, which are associated with durvalumab treatment, were also assessed. This is an analysis of the incidence and management of pneumonitis, radiation pneumonitis, as well as the immune-mediated adverse event in the Adriatic trial. So this is a reminder of the design of the study, which included patients with limited stage small cell lung cancer without disease progression following concurrent chemoradiation. And they were randomized into 3 arms, durvalumab versus placebo, or a combination of immune checkpoint inhibitor. And we'll focus here on the 2 arms of durvalumab and placebo. This is an exploratory safety analysis, which included immune-mediated adverse event as well as radiation pneumonitis, which is defined as any of the following: alveolitis, acute interstitial pneumonitis, immune-mediated lung disease, interstitial lung disease pneumonitis, radiation fibrosis, or pneumonitis. Immune-mediated adverse event were defined as a special interest consistent with immune-mediated mechanism, which require treatment with systemic steroid, immune suppressant, or endocrine therapy. The incidence of pneumonitis was more in the durvalumab arm, 38 versus 30%, but with the grade 3 or higher generally was very low, 3 compared to 2.6, but that led to discontinuation of treatment in about 9% in the durvalumab arm. This is to show whether or not different baseline patient-related characteristic could have been associated differently with the incidence of pneumonitis. Which was not the case, only that the incidence of pneumonitis was reported more in patients of Asian ethnicity. Again, there was no different related to treatment-related factor, such as the type of chemotherapy, carboplatin or cisplatin, the radiation dose schedule once or twice daily, as well as the total dose or other factors. The median time to onset of pneumonitis was the same between durvalumab and the placebo, about 56 days. Those patients were managed for the most part with steroids. This is to show the median time to resolution of pneumonitis, which was shorter in the durvalumab arm compared to the placebo. This could be related to the fact that there were more patients received steroid and high-dose steroid in the placebo. Other consideration is the mechanism of action of immune checkpoint inhibitor related pneumonitis versus radiation pneumonitis are not necessarily the same. Moving to immune-mediated adverse event, which were also reported more in the durvalumab arm, the incidence of grade 3 or 4 were generally low, about 5%, and that led to discontinuation of treatment in about 7% in the durvalumab arm. The time of onset of a different type of adverse related event, which is not different from what we know from previous experience with durvalumab treatment in this setting. Those patients were managed for the most part with steroid. Some of them received high-dose steroid, and one patient received treatment with infliximab. This is to show the median time to resolution of different immune-mediated adverse event, and the profile here is specific to each site or tissue involved. So in conclusion, although pneumonitis was common in both arms, most events were of low grade and manageable. The median time of onset was similar between durvalumab and the placebo. The median time to resolution of pneumonitis was shorter in the durvalumab, and the use of steroid to manage these events were more frequently in the durvalumab arm. The frequency of treatment discontinuation was higher in the durvalumab arm, almost 9% compared to 3%, and this is mostly driven by grade 2 event. Immune-mediated adverse event in durvalumab were consistent with what's known already in the post-chemo RT setting, mostly of the low grade and were manageable, which further support the risk-benefit profile of the durvalumab and the post-chemo RT for limited stage disease. Thank you.
Thank you, Fahad. We'll move on to the next presentation by Dr. Hamid Al-Husseini. He's my colleague and consultant medical oncologist at King Faisal Specialist Hospital Research Center in Riyadh. He's the chairman of medical oncology department there. Dr. Hamid is specializing in lung and gynae malignancy, and he will present about hypofractionated radiotherapy plus concurrent chemotherapy with or without consolidation immunotherapy in patients with locally advanced non-small cell lung cancer, the GASTO 1052 study. Dr. Hamid, the floor is yours.
Assalamu alaikum. I would like to thank the organizing committee for inviting me to participate in this conference as a medical oncologist. Thank you. So I'm going to talk about this trial that presented by Hugh Liu. He's a professor of radiation oncology from China. So this is a hypofractionated radiotherapy plus concurrent chemotherapy with or without consolidation immunotherapy in a patient with a locally advanced non-small cell lung cancer. So, and this research was supported by GASTO Foundation. So we know that the Pacific trial showed clearly improvement in the treatment of unresectable locally advanced non-small cell lung cancer. And this is by combining immunocheckpoint inhibitor with radiation therapy in stage 3 non-small cell lung cancer. However, the intrathoracic recurrence remained the predominant pattern of disease progression in the Pacific study, and you can see around 81% developed intrathoracic recurrence as compared to only 15% developed extrathoracic metastatic progression. The Pacific 2 and the Keynote 799 tried to add the immunotherapy as a concurrent with the chemotherapy, with the radiation therapy, however, did not achieve ideal result. This study was conducted based on the prior phase 1 dose escalation study. So this is a phase 2 non-randomized single-arm study in which patient with unresectable stage 3 non-small cell lung cancer, treatment naive, good performance status, patient will be treated with a split course hypofractionated radiation therapy, 60 gray plus concurrent chemotherapy weekly, docetaxel and cisplatin. If a patient achieve complete remission, partial remission, or stable disease at 8 weeks, will be treated with the consolidative immunotherapy for 1 year. The primary endpoint was progression-free survival. Secondary endpoint was overall survival, overall response rate, and safety profile. So this is the flow diagram. So the patient will be treated initially with a hypofractionated concurrent chemoradiation, 30 gray over 6 fraction. At the same time, patient will receive weekly chemotherapy, docetaxel 25 milligram per meter square and cisplatin 25 milligram per meter square for 6 weeks, then mid-treatment evaluation. And after that, the patient will be treated again by hypofractionated concurrent chemoradiation therapy post, in addition to weekly chemotherapy. So 114 patients screened for eligibility, around 104 allocated to treatment protocol, 2 discontinued hypofractionated chemoradiation because 1 patient with a lung infection and 1 patient grade 3 pneumonitis. So 102 completed split hypofractionated concurrent chemoradiation therapy, 49 received consolidation immunotherapy, 53 did not receive consolidation immunotherapy, and the reason was mainly because declined treatment protocol, developed grade 2 to 3 pneumonitis, or lung infection, grade 2 hemoptysis, brain metastasis, or using alectinib. So patient characteristic, median age was around 60. Most of the patients were male, never smoker in around 88.5%. Most of the patient was stage 3B, around 56%, followed by stage 3C, 25%. Adenocarcinoma was around 49%, EGFR mutant in around only 7%, and most of the tumor was central. So the complete response achieved in around 7%, partial response in around 84%, so objective response rate was around 90%. Median progression-free survival was 20 months, and at 2-year progression-free survival was around 49%. 2-year overall survival was around 63%. When they look for the median progression-free survival comparing the patient received consolidative immunotherapy versus without, you can see the median progression-free survival was prolonged with the immunotherapy. It was around 26 months versus 17 months with the p-value 0.04. Overall survival was prolonged with the patient who received consolidative immunotherapy. It was not reached versus 37.8 months. When they look for the safety, only 2% discontinue lead to the discontinuation of the hypofractionated concurrent chemoradiation therapy. Grade 3 or 4 adverse event occur in around 40%. The most common adverse event, grade 3 or higher, was mainly lymphopenia. It is around 27%, followed by esophagitis, 3%. Pneumonitis or radiation pneumonitis was 3%. And you can see grade 2 was 24%. Grade 3 to 4 was only 3%. When they look for the total lymphocyte count, they found that the total lymphocyte count reached to the lowest point at mid-hypofractionated concurrent radiation therapy and then subsequently recovered. When they look for the specific CD3 T lymphocyte, the same. It reached the lowest point at mid-hypofractionated concurrent radiation therapy and then subsequently recovered. When they look for the neutrophil to lymphocyte ratio, it reached the lowest point at the end of the hypofractionated concurrent chemoradiation therapy. So by looking to the univariable and multivariable analysis of progression-free survival, you can see the age and mainly the total lymphocyte count that showed clearly independent associated with the progression-free survival regardless of receiving consolidation immunotherapy. So for patients with the total lymphocyte count still above 1, the median progression-free survival was 38 months as compared to only 18 months for a patient with the lower total lymphocyte count. So in conclusion, this study is the first phase 2 study to evaluate the feasibility and efficacy of a split course hypofractionated concurrent chemoradiation therapy with a consolidative immunotherapy in unresectable locally advanced non-small cell lung cancer. hypofractionated radiation therapy and hypo-post delivered at a 5 gray per fraction to total dose of 60 gray in a combination with a concurrent weekly chemotherapy produce a favorable local control and survival outcome in a patient with a locally advanced non-small cell lung cancer while accepting a moderate toxicity. The combined treatment of consolidative immunotherapy and split hypofractionated concurrent radiation therapy brought the progression-free survival benefit. Thank you.
Thank you very much, Dr. Hamid. Now it is my pleasure to present Dr. Samahir Al-Ashram, radiation oncologist in the National Guard Hospital in Jeddah. She completed residency at McGill University and fellowship in radiation oncology at the Western University in London, Ontario. She specializes in lung and SPRT treatment, and she's going to present birifenidone in the treatment of radiation-induced lung injury? No? Oh, sorry, another lecture. Accelerated hypofractionated chemoradiation followed by stereotactic ablative radiotherapy boost for locally advanced unresectable non-small cell lung cancer. Final results from a non-randomized controlled clinical trial.
Assalamu alaikum. Good evening, everyone. This is the disclosure for the study. So just a quick review over the last few years, or actually since the 80s, the treatment paradigm shifts for unresectable stage 3 non-small cell lung cancer. There have been several trials investigated the sequential versus concurrent radiation, chemoradiation, single agent, double agent, the rule of induction followed by concurrent chemoradiation until in 2011, where the RTOG 9410 trial has been published. This trial investigated the role of concurrent versus a sequential chemoradiation, and it showed the improvement in overall survival with the concurrent arm with about 6% improvement. So since then, the concurrent platinum doublet chemoradiation has been the standard of care with the radiation dose of 60 to 63 gray. After that, a few trials have been published. None of those had succeeded in significant improvement in progression-free survival nor overall survival compared to placebo following concurrent chemoradiation. One of those trials is the RTOG 0617 that investigated the escalation of radiation dose from 60 to 74 gray. Patients were randomized to 60 versus 74 gray, and they investigated again also the role of cetuximab in unresectable local advanced non-small cell lung cancer. Interestingly, that the higher dose of radiation showed inferior result comparing to the 60 gray regarding the overall survival and the local failure rate, plus increased toxicity. Then in 2017, we have the landmark trial, the Pacific study, which investigated the addition of durvalumab after concurrent chemoradiation. So conventional dose escalation to more than 60 gray resulted in inferior overall survival and local control, as mentioned. The concurrent platinum-based chemotherapy with 60 gray have been followed by durvalumab has been the standard of care for unresectable stage 3 non-small cell lung cancer based on the Pacific trial result. However, the dominant pattern of failure remain loco-regional, which admit the need to improve the thoracic control and distal control in the Pacific area. Is there a better way to deliver definitive chemoradiation using a modern radiotherapy technique? So this question led to the current study that I'm presenting now. Just a review of the Pacific trial. So this is a phase 3 randomized trial, including patients with stage 3 non-small cell lung cancer. So those patients, after receiving chemoradiation and had no progression, they were randomized to either durvalumab or placebo. The long-term follow-up showed that significant improvement in overall survival as well as progression-free survival with the durvalumab. The incidence of new lesions as well were way lower with the durvalumab arm. However, if we look carefully to the table, we can find that most of the local regional recurrence, most of the recurrence happen local regionally within the lung or lymph node. The durvalumab also reduced the time to develop distal metastasis. So what is the hypothesis or the rationale for hypofractionated chemoradiation followed by SABR boost? Applying technical advances of SABR with hypofractionation, thoughtful margin design, and biological adaptation may reduce toxicity, improve outcome, and shorten the treatment course. So in this trial, it's a non-randomized controlled trial, enrolled 28 patients with the stage 2 non-operable or refused surgery and patient with the stage 3 non-small cell lung cancer. Those patients receive concurrent chemoradiation. The radiation dose was 40 gray delivered in 10 fractions. And after that, like after the 8th or 9th fraction, those patients underwent for another staging PET scan, as well as rescanning with 4D simulation. So the first 10 patients, they received a boost of 25 gray in 5 fractions. Then the second group of patients, they received 6 gray, a total of 30 gray delivered in 5 fractions, and then 35 gray in 5 fractions. So patient characteristic, the median age was 70, most of them male. Vast majority had adenocarcinoma, and most of the patients had stage 3. If you look at the clinical outcomes, so the primary endpoint of this trial was to determine the maximum tolerated dose, while the second endpoint was overall survival, local control, and progression-free survival. So if we just look at the p-value through the all outcomes, overall survival, local control, and progression-free survival, we can see there is no difference. However, we can see in the overall survival, the lower dose in the orange, and then the intermediate dose in blue, and the dark blue is a high dose of boost that stratified based on the boost. So we can see that the inferior outcome with the low dose, the 25 gray in 5 fractions. Regarding the local control, of course, the higher dose provide better local control. And regarding progression-free survival, we can see that the low dose has an inferior outcome. However, by the end, that was non-statistical significant. For the local control, this is also like a divided according to the boost dose, low, intermediate, high dose. We can see that the 1 year and 2 year local control rate is very high overall, all 3 groups of patients. The progression-free survival was higher with the intermediate dose, as well as overall survival. For the toxicity, there was no grade 3 toxicity or higher in the intermediate group. However, there was 2 patients had the grade 5 toxicity with the high dose boost. So just to summarize the paradigm for non-small cell lung cancer management. So regarding the early stage, we all agree that a patient, if they're surgically candidate, they go for surgery. Otherwise, SBRT is an excellent alternative option. For stage 4, standard of care is the systemic therapy. Talking about the stage 3 non-small cell lung cancer, stage B, they go directly for concurrent chemoradiation followed by durvalumab. And for stage 3A, we have to evaluate the patient for surgery. If they're candidate, they can receive peri or preoperative chemoimmuno followed by surgery or chemoradiation. So unresectable patient, chemoradiation followed by immunotherapy, and the progression-free survival 17 months based on the Pacific trial. If patient if resectable patient, they receive pre-surgery chemoimmuno followed by surgery and then systemic therapy, with event-free survival is 32 months based on the CheckMate trial. The COAST trial, this is a phase 2 that enrolled almost 190 patients. They investigated the addition of other drugs to Pacific, to the durvalumab. So concurrent chemoradiation followed by durvalumab, plus minus the 2 molecular antibody. and it showed that a combination of both drugs show superior outcome in regard to progression-free survival comparing to durvalumab alone. So the conclusion here, both locoregional and distal recurrence remain suboptimal for unresectable stage 3 non-small cell lung cancer treated with a specific Pacific regimen. Giving a precise definition of resectability and with improved outcome utilizing pre- and perioperative chemoimmuno along with surgical resection, it's unclear which patient should receive which treatment paradigm. Hypofractionated concurrent chemoradiation followed by SABR is an early phase single one is institutional prospective clinical trial for stage 2 and 3 inoperable, utilizing hypofractionated chemoradiation followed with SABR boost, demonstrating promising locoregional and disease control and safety signal. Larger randomized studies are needed to further this approach in combination with checkpoint inhibitors and other novel drugs. Thank you very much.
Assalamu alaikum. Now we'll move on to the discussion. May I ask the presenter, Dr. Ahmed, Dr. Fahad, Dr. Hamid, to join the podium? Mustafa, can we have extra chair? Yes. Extra chair. Thank you. So we'll start with the questions from the audience. Yes. Dr. Laith, I'll give you a...
Thank you for the presenters. For the Dr. Ahmed Bouchehri, the first presenter, this is phase 3 negative trial, like show that atezo is not useful. What's about phase 2 for this? Like, is it like was positive, so they moved to phase 3 or not? I'm not aware about the phase 2 trial of atezo. And regarding the third presenter, 30 in 6 and then split and followed by 36. Is the fractionation like twice weekly or daily? Because 30 in 6 is 5 gray per fraction. Is it like daily or every other day? Just I want to make sure about this. And like what is the next after this trial? Is it like planning to do like phase 3 trial now, if you are aware about this? So these are my 2 questions. Thank you.
First question is Dr.
Like, I'm not sure, maybe anybody else is aware of this. Not sure if there was a phase 2 trial for this.
The NRG LU005. Is that the question, Dr. Lay?
Yes, so this is multi-institutional, Japan, US,
Yeah.
and it is phase 3 trial. So
There is a
why
phase
they
2
moved to phase 3 trial
Yeah.
is phase 2 was positive, so they moved to phase 3,
Yeah.
and the phase 3 is negative.
Yeah. Personally, I'm not aware, I'm not sure, Dr. Lay, actually. Yes.
You know, most likely because immunotherapy almost similar. I mean, checkpoint inhibitor like durvalumab, atezolizumab, pembrolizumab. So if durvalumab showed clearly advantage post-concurrent chemoradiation limited stage, and giving durvalumab showed clearly survival advantage. So most of the other pharmaceutical, they will use the same immunotherapy as a phase 3 trial because most likely it will be positive. Less likely to be like phase 2 trial, but most likely because they know that it is the similar and durvalumab showed efficacy. Why not to use atezolizumab or pembrolizumab?
Yeah. And this leads me to question, Dr. Hamid. This LU005 trial, they use this atezo was clearly negative trial, but the Adriatic trial, they use it in adjuvant setting, the durvalumab, and it's clearly positive trial. What's the hypothesis here? So is it the timing of immunotherapy? Is it a type of immunotherapy? Is the patient populations? What do you think, Dr. Hamid, and what do you expect the future randomized trial going to be?
I think it could be, most likely, we are seeing in other tumor that sometimes you do a trial on type of immunotherapy to become positive and the other immunotherapy to become negative. So it could be from the type of the immunotherapy or because of patient characteristic difference.
Right.
And in this trial, they use atezolizumab with the radiation therapy,
Yeah.
with the chemo, and then after that, maintenance. So maybe adding atezolizumab to the radiation therapy cause more toxicity, something that affects the patient to continue into treatment after that. Maybe this is the reason.
Where do you see the future trials, Dr. Hamid? Do you think
I think now adding immunotherapy to concurrent chemoradiation to look like doesn't add advantage. It is mainly like maintenance. So maybe and giving immunotherapy as a maintenance it doesn't give a good control locally. So
Okay.
I think in the future should be more improvement in the radiation therapy to control the locally while immunotherapy and chemo will control the distant.
Thank
So
you.
immunotherapy, يعني, as a medical oncology, we improve,
Yes.
but more in radiation oncology.
Okay, good. Other questions from audience? Yeah. Okay.
For the,
Yes.
they asked me question, but I'm not a radiation oncologist.
With-
But I think, I mean, to look like fraction daily, because it is like 30 gray, 5
And 6.
fraction. So it is like 6 weeks fraction daily, and they give at the same time weekly cisplatin docetaxel.
Yes.
And most likely it may go, I mean, the next for the phase
Yes,
3 trial.
it's very weird, dose and fractionation. Yes.
Another also, negative trial is the Pacific 2, which they did also concurrent Durva as well as maintenance. Also, this was negative.
Yes.
So it looks like, adding immunotherapy with concurrent chemo is not the way to go.
Yes.
The other thing, there was already selection in the Pacific that those who did not progress are eligible compared to the other trial.
Excellent. Then we have one questions here. Father, Doctor.
Thank you for your presenters. Thank you for all. My name is also Dr. Laith Samhouri. I'm here new in Middle East. I was the former last 11 years in Germany. So I want to ask you, please, do you believe that radiation doses for small cell cancer higher than 60-63 bring the advantage for the patient? This is more of the cases in 60 gray with hypofractionated or with hyperfractionated. But I want to ask, is this here applicable in your institutes to do hyperfractionated radiotherapy for all patients with small cell cancer? Thank you. Overall, it's about BED. Yes, it's biological effective doses. Therefore, this it's better than normal fractionation. Thank you.
Okay. Go ahead. Your thoughts.
Well, BID treatment is, logistically challenging, so we don't do it. And I'm not sure in the context of the Adriatic whether or not this will make any difference. When they did the subgroup analysis, it didn't really matter. The difference in median survival is almost 2 years. So it's hard to believe that changing the fractionation will make the difference.
Okay. Yes, Dr. Paul.
Yeah, thank you for the talks. They're all very interesting. It's just a practical question for just following up on the idea of small cell. You know, there's the Norwegian data that shows that doing BID but escalating the dose to 60 BID had some survival advantages. And I was just wondering, in practice, given that we're integrating immunotherapy after chemoradiation for a limited stage, do you still believe that there's any benefit to dose escalation, or do you believe that adjuvant immunotherapy is leading to much better outcomes where we don't need to worry so much about dose?
Samah. Yeah, so the Norwegian was the phase 2 trial, صح? Was, yeah.
So for disclosure, I treat GI and breast, so I'm kind of against for the lung session. But I would say definitely I agree with Dr. Ahmed that the logistics of BID is really difficult for frail patients with lung cancer. In the US, reimbursement is another problem that honestly you are not charged twice for a radiation treatment per day. So it's a loss to the hospital and there will be pushback. That's why it's not very popular treatment, even when we had only the BID data for small cell lung cancer. This was a subset analysis, I believe, that is not even, I don't know if it was planned upfront or not in the study. So until we have, and that was the recommendation from the authors here, until we have upfront head-to-head study showing clear survival benefit that would trump any financial constraints and logistic constraints. I don't see that would be a common practice anywhere, definitely not in the US. I think that would be very, very challenging, really.
Yes. Maybe we'll have one question.
Thank you. It was really excellent talk and selections of those in the lung cancer session. I think just the comment of that small cell lung cancer, as you know, is a systemic disease, and that's clearly seen of the benefit of the immune therapy in the extensive stage and moving more benefit in the limited stage. And that again shows more than 2 years, that's the improvement. I think whatever we are now is improved in the radiation field also. The part of the systemic treatment that is very important, especially the maintenance immunotherapy. And just Fahad, he showed that the toxicity even with durvalumab after the immunotherapies, that there is no that much of the pneumonitis. I think the way of giving them more and more of the maintenance therapy, this is the way of treatment of the small cell lung cancer, especially in the limited stage.
I totally agree, Doctor. Yeah. Any comment, Dr. Hamid? Okay, fine. Good. I think with the time limitation, I would like to thank you, speakers, and Prof. Tamer. I think we need to move on to the next session, which is the GI session. I would like to welcome Prof. Ahmed Shamsi. He is the president of Emirate Oncology Society, as well as he's the CEO of the Burjil Medical Center. He came all the way from Emirates to us to share his expertise in GI malignancy. And also, I just heard yesterday or 2 days ago, you became a visiting professor at Harvard Medical School. Is that correct, Prof. Ahmed? MashaAllah, congratulations, wallahi. This makes us very proud. MashaAllah, MashaAllah. And also, the other moderator, Dr. Ahmed Sabbagh. He's a radiation oncologist, consultant radiation oncologist at National Guard Hospital here in Jeddah. The floor is yours. Thank you so much.
السلام عليكم ورحمة الله وبركاته. أولا شكرا جزيلا، جزاكم الله خير على استقبال طيب. مفروض كنت أغير شماغي أنا أحمر، بس المرة الجاية إن شاء الله بإذن الله. طبعا GI is my favorite subspecialty. I do treat different cancers because in UAE, unfortunately, we're not subspecialized, but GI actually is my subspecialty and the area that I enjoy more. Even though I have to treat breast cancer, but GI is still my favorite. So welcome, Dr. Ahmed, and we'll go move now to the GI session. We'll first would like to welcome Dr. Mohammed Al-Faiz, who will be talking about outcome and immune responses from innate randomized phase 2 trial, sutilingumab immunotherapy during neoadjuvant therapy of rectal cancer. Dr. Mohammed Al-Faiz, he's a consultant clinical oncologist at Prince Sultan Military Medical City in Riyadh. Welcome, Doctor.
Thank you very much, Dr. Ahmed, and thank you very much for the committee for inviting me. So I'm presenting a phase 2 trial, which is very interesting. It's using immunomodulating agent with radiotherapy, which is a new things in radiotherapy. So this is a trial done, I think, mainly in Dallas Southwestern Medical Center, and there is a few center joined. So I'm just going to go through what's the lab which done it is very they have all studies available. So they do like preclinical animal work, cell work, and then they take it to phase 1, and then they go carry on with phase 2 and phase 3. So the history of rectal cancer management is going back when you have the long course chemoradiotherapy, then you wait 6 weeks, and then after that you go for surgery and followed by adjuvant chemotherapy. Then we have the alternative treatment, which is giving short course radiotherapy. You wait 1 week, which is the Swedish trial, and then you operate, or you wait a longer and then you operate. Then we had the Polish trial, which came 2016, which gives short course, then a chemotherapy for 6 weeks, and then for surgery. We have also then that concept of total neoadjuvant chemotherapy, which came, you give chemotherapy for 4 months, then chemoradiotherapy for 5 weeks, then you wait for 8 weeks, and then you go for surgery. So there is different approaches which can be used, and that's make this trial slightly challenging, the other one that designed it. So they have to choose one among of all these approaches. So when you go back, that radiotherapy, there is some evidence at the cellular level, radiotherapy modulate immune response at the macro environment by manipulating BD1, CTL4, and then we have the CD4 agonist, which is actually modulate antigen presenting cells, macrophage killing cells, and promoting dendritic cell maturation. When you combine, and the idea of innate trial is combining those approaches and to see the effect at the clinical level. So at the clinical level, so if you have usually at the cellular level, you have macrophage, dendritic cells, B cells, all of them have CD40 receptors. And then if you target them with the agonist, then they will have cell-mediated response, and this will target the cancer cells. At the other side, you'll have radiation, which the radiation itself can mediate cell infiltration, which target the tumor cells, or can also which have like synergistic effect with CD4 agonist. So using a human model to study this effect, so this is this is the group who run these trials. This is the PI investigator, Nina. Sorry. Now. Okay. Now, this is the design. So they decide to use Rapido approach with slight modification. So they have short course radiotherapy, waited for 2-3 weeks, and then they give FOLFOX chemotherapy 6 cycles rather than 8 cycles. Dr. Hamid is here, so he's probably, I need to be very careful with the number of chemotherapy you're given. Then you wait, and then you do an MRI, and then you do surgery. This is the standard arm. Then the tested arm, what they're looking for is basically their primary endpoint is pathological complete response. Secondary endpoint looking for the safety and toxicity, disease-free survival at 3 years, and overall survival at 3 years. Their subject, well, the sample size subject they're targeting is 58. They're looking to 3 to 2, and they're looking for over 62 months. Unfortunately, they started at the peak of Corona endemic, so back in July 2020, and this has affected the accrual of this trial. Unfortunately, they couldn't really reach 58 subjects. So the tested arm, basically the tested arm is they will do the anti-CD40, they will give it day 3 of radiotherapy, they will give it each cycle of FOLFOX until cycle 5, with the chemo. During the time, they will go at cellular level, they will do a biopsy before radiotherapy, biopsy before starting chemotherapy, and then when they do surgery, they will collect it. They will do a blood test, also similar time they do a biopsy, and except during radiotherapy. And this is give them like a analysis or at the level pre-radiotherapy, during radiotherapy, and then after completing the CD40 agonist. And they looking to incur, actually they aim to do the newly diagnosed locally advanced rectal cancer stage 2 or high risk stage 2, or high risk stage 2 or stage 3. They also included those with limited liver metastasis, but none of those patients been included in this trial. The first one was in July 2020, the 4 centers involved, and they end up with 30 patients rather than 56. So this is the criteria of the patient. Now, looking at the safety or tolerability of this, it is well tolerable and very safe. If you look at the control arm, which is the standard form, it is more of G3, G4 toxicity, which is because of the size of the sample, not really reflecting that. That's the problem with this. There's one patient who died, unfortunately, during chemotherapy with the control arm, and the rest is similar. And this is what patient characteristic. Most patients are T3, T4, N1, N2 disease. And this is the randomization. So there's 19 patients being randomized for the CD4 agonist, with 11 patients on the control arm. One patient died during chemotherapy because he had perforation, unfortunately, and passed away. And the data shows basically as the agonist there's more pathological complete response compared to the control arm, and much more response, major response in the control arm, 60%. Now, at the cellular level, at the MRI imaging, so they looked at the tumor size at the radiotherapy, prior radiotherapy, and then after radiotherapy. There is significant reduction in the tumor size, which is statistically significant. There is, and also on the tested arm, there is a tumor reduction, which is statistically significant. And looking at the tumor size reduction, there is more tumor reduction with the tested drug, which is the CD40 agonist, but not statistically significant, unfortunately. And I think it's all reflect the sample size rather than anything else. And then they went back and because they had collected tissue, they collected blood test. Yeah, and they looking at the cellular level. They wanted a messenger, they tested this looking at the single-stranded RNA. Why is that? Yeah, single-stranded RNA and double-stranded RNA to look at the immune response, what's happened at the cellular level in the blood and the tissue itself. So basically, there is more immune response with radiotherapy, and it's actually more prominent if they give anti-CD4 agonist. And this is actually reflecting there is more myeloid infiltration increase if you give CD4 agonist, and which actually has evidence of adaptive immune response. Sorry, I'm doing this as the machine is, I don't know what's happened here. It's keep moving. Yeah, so, and in summary, so this is a small randomized controlled trial with novel agent. It does show there is this modulation of immunotherapy with chemoradiotherapy is safe and feasible. There is definitely impact of pharmacodynamics, impact of the CD40, which is can be taken further in a bigger sample size and also stage 4-3. And there is evidence at cellular level there's adaptive immunity. And that's it. Okay, any question? Thank you very much.
Thank you. Thank you very much, Dr. Faiz, for excellent timekeeping. I would like to welcome Dr. Amr Taha, Consultant and Chairman of Radiation Oncology Service at King Fahd Specialist Hospital in Buraydah. He will kindly talk to us about a multi-center phase 3 randomized clinical trial comparing the efficacy of an adjuvant SOX chemotherapy regimen with SOX combined with a simultaneous radiotherapy regimen after D2 radical resection for gastric cancer. Thank you very much.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Mr. Chairman. Thanks for the organizing committee for inviting me to share in this meeting. My talk today is about a multi-center phase 3 randomized clinical trial comparing the efficacy of SOX chemotherapy protocol as an adjuvant treatment for advanced cancer stomach who had radical resection with D2 lymph node dissection versus SOX chemotherapy plus radiation therapy. This study took place in west of China. It's multicentric. It was presented as an abstract in last Astro. Maybe before we go to the details of our study, you may agree with me that the local control is still a challenging issue for advanced gastric stomach. And since the early presentation of McDonald's trial in 2001, who improved 3-year overall survival in patients who are having advanced cancer stomach, who received post-operative chemoradiation versus those who didn't receive adjuvant therapy. The evidence is very unclear until the ARTIST-2 trial that published in 2020 that failed to prove a significant difference in the outcome of patients who received chemoradiation versus those who received chemo only. Today's study is testing patients with T4 and or N positive adult patient from 18 to 70 years who had D2 radical surgery for 6 cycles of SOX chemotherapy, S1 plus oxaliplatin, Q3 weeks, versus 1 cycle SOX radiotherapy, 28 fraction, aiming for 50.4 gray, together with S1, followed by 3 cycles of chemotherapy protocol. And the primary endpoint was the event-free survival, while the secondary endpoint was the toxicity and the overall survival. This is the enrollment of the patients. 620 patients were enrolled in this study, nearly half of them for each arm. Unfortunately, 24 patients on each arm had discontinuation of their treatment. The radiotherapy arm, 24 has interruption of the radiotherapy protocol, while the chemotherapy arm had interruption of their chemotherapy as well. But surprisingly, that 64 patients, which is nearly 20% of the radiotherapy arm, refused to receive radiation therapy. And the analysis was made based on the initial enrollment of all patients. This is the table showing the basic characteristics of the patient. And as you can see on the right side column, it's well balanced between the two arms with no significant difference regarding the age, the ECOG, the pathology, the stage. Note that here is that only less than 5% of the patient had N0. So at least 95% of each arm is N positive. This is the primary endpoint. As you can see, there is no significant difference after nearly 5 years of follow-up between the disease-free survival in each arm, with a little bit non-significant higher result for the radiation arm. So adjuvant chemoradiation therapy, 5-year disease-free survival is 60, while it is nearly 58 in the chemo-only arm. Even in subset or subgroup analysis, there is no difference between the two groups, not in any subgroup, not even in the lymph node positive N2, N3. No difference in whatsoever what subgroup analysis in this study between the two arms. Secondary endpoint, the overall survival, as the disease-free survival showed no significant difference between the two arms. Again, little higher overall survival in the chemoradio arm, but not significant, 74 versus 72 at 5 years. So there is no significant difference between both arms, neither in the disease-free survival nor in the overall survival, not even in the toxicity. So there is no like frequent grade 3 or 4 toxicity. The most common grade 3 and 4 toxicity was the anemia and leukopenia, and there is no difference between the two arms regarding the toxicity. So in conclusion, based on this trial, patients who have T4 or N positive status post total gastrectomy, radical gastrectomy with D2 dissection, there is no added value from radiation therapy to the chemotherapy as an adjuvant therapy, neither in the disease-free nor in the overall survival. I got still 5 minutes. So can I just comment one? Okay, I got 5 minutes. So to complete it, recently in the last issue of the Red Journal, there is a smaller randomized controlled trial again in China, 300 patients, use SOX versus SOX radiation therapy, a little bit longer, 8 cycle rather than 6 cycle. The chemoradi was sandwich, 4 cycle or 6, then radiation, 45, even less dose, and completion of chemotherapy. And the disease-free survival improved in the high-risk group, which they defined as N2 patient and patient who has involvement of lymph node that is not perigastric. So that's maybe a more recent compared to this one. Okay.
شكرا دكتور نضالي. We'll have more discussion inshallah. Thank you so much. Now we'll move to a very interesting presentation with my friend and colleague, Professor Tamer Rafat, who's Director of Clinical Research, Director of the Adaptive Radiation Therapy, Intraoperative Radiation Therapy Program, and the lead of the GI and Breast Radiation Oncology Program at Loyola University Medical Center. He will be highlighting the new adjuvant chemoradiation cross versus FLOT in the esophageal adenocarcinoma, ISPEC randomized, controlled, prospective, multicenter, phase 3 trial.
Assalamu alaikum. My name is Tamer Rifat. Thank you very much, Dr. Hamid, Dr. Muhammad, the organizing committee, for inviting me to give this presentation. Today, we're going to discuss the interesting results of ASOPEC study, which is a comparison between neoadjuvant chemotherapy or chemoradiation per cross protocol and preoperative chemotherapy FLOT in esophageal adenocarcinoma. It is a randomized controlled phase 3 multi-center study. So in this presentation, we're going to give the context why, how they designed the study, based on what, understand the main results and the take-home message of the study. So I believe everybody in the room hopefully is aware of CROSS study, which was and remain in many institutions a standard of care, comparing neoadjuvant chemoradiation to upfront surgery in esophageal cancer. The study included both squamous cell carcinoma and adenocarcinoma. While squamous cell carcinoma had better results, still adenocarcinoma also did better than upfront surgery. And then there was the FLOT4 study, which was comparing the standard MAGIC protocol, if you remember that, perioperative chemotherapy with ECF versus FLOT, which is a more advanced, stronger chemotherapy. And it did show a benefit for FLOT over ECF. The comparison between perioperative chemotherapy and trimodality therapy did not result in any improvement per neoAGIS, so that's a negative study. The design of our study was CROSS, which is neoadjuvant chemoradiation. They stopped at 41.4 gray, which usually is less than what we would prescribe in our daily practice. And then 4 to 6 weeks rest followed by surgery, compared to perioperative FLOT, full dose of chemotherapy with the surgery in between. Inclusion criteria included adenocarcinoma. So for the younger trainees in the room, that does not apply in squamous cell carcinoma. So the study included only adenocarcinoma. They used the older staging, TNM7, which was the standard back then. Clinical stages included T1, node positive disease, or T2 to 4A, N0 or N1. Also remember, CROSS did not include T4 disease. They wanted to make sure those are esophageal cancer tumors, so the epicenter had to be within 5 centimeters of the EG junction, and it had to extend to the esophagus. At the time of the presentation, they were able to report the primary endpoint, which was the overall survival. Also kind of key secondary endpoint that they had analysis, which was included progression-free survival, post-operative pathological stage, post-operative complications, and site of tumor recurrence. The remaining secondary endpoints were not available for analysis at the time of the presentation. The objective was to show a superiority of FLOT over CROSS for primary endpoint, overall survival at one-sided significance level of 2.5% with 90% power. They assumed that at 3 years, the overall survival rate should be 55% for CROSS, 68% for FLOT, corresponding to a hazard ratio of 0.64. Remember the 68% aim that they assumed is going to happen. Require a total number of 218 events. A total of 438 patients were required to power the study. Primary analysis to follow the intent to treat principle. which means every patient included those who dropped or did not meet the criteria for analysis. Study started enrollment in January 2016. Enrollment was really good. They finished in January 2020, right before the COVID starts. They had 438 patients who underwent randomization. 221 underwent for FLOT and surgery, 217 cross plus surgery. Interestingly, there was 11 patients with metastatic disease in the cross arm, only one in the metastatic disease. The explanation by the authors is that in many centers in the study, PET was required for planning of radiation. So more patients had PET scan in the cross arm, but not in the chemotherapy arm. And they kind of made an assumption that there must have been other metastatic patients in the chemotherapy that they didn't know, and they still believe that was an equal cohort of patients. But other than that, 21 patients in the cross study did not start allocated neoadjuvant chemotherapy compared to 14 in the neoadjuvant chemotherapy only arm or perioperative arm. Looking at the criteria, baseline characteristics, pretty much balanced. The mean age was 63 in the FLOT, 62.6 in cross. That's a little bit older than the initial cross, which was younger patients. Gender was kind of comparable. Performance status, a little bit more frail patient than the initial cross. More than a quarter in each arm had a performance status more than 0. They included few, approximately 5% in the cross arm, 8.6% in the FLOT arm was T4. T4 was an exclusion, I believe, in the cross study, and more node positive disease. So older patients, more advanced patients, more patients with higher likelihood of distant metastatic disease who would benefit from systemic therapy more. Completeness of therapy, 92% in each arm. 93% completed at least 4 cycles of neoadjuvant FLOT. 97% completed 3 or more. In the cross arm, 75% completed 5 cycles of concurrent carbotaxol, and 94% completed at least 4 cycles. Again, they stopped at 41.4 gray. And it comes at no surprise, and Dr. Hamid, correct me if I'm wrong, that in the adjuvant setting, most patients do not complete adjuvant setting. So 56% only completed the 4 cycles of FLOT in the adjuvant setting. Again, 41.4 is not standard that we use in our daily practice. Pathology are 0 resection for 94% in FLOT, 95% in cross. Nodal pathologic node positive disease was 49% in FLOT, 44% in cross. Pathologic complete response, which was defined by YP-T0, YP-N0, 17% in FLOT compared to 10% of cross. And they combined the complete response and near complete response, which was a little bit higher in the cross protocol. Again, the main point here is the pathologic complete response was higher with FLOT. Remember, those received 4 cycles of chemotherapy, longer time before surgery, compared to the 6 weeks of radiation, or actually less than that, and then 6 weeks to go to surgery. So operative morbidity was comparable, I believe. There was no significant difference between both arms. Still, it's hard to argue these curves, right? So there was clear survival benefit for FLOT compared to cross. I can explain why if I'm being asked by anyone of the audience, but now I'm presenting the study, so I should be in favor of these results. But the hazard ratio is 0.7. Median overall survival was 66 months in FLOT compared to 37 in cross. 3-year overall survival, 57 in FLOT compared to 15 cross. That came kind of disappointment. They expected to be 68, if you remember. It's way less than that. And of course, the projected 5-year overall survival rate was 50 compared to 38%. Again, those are impressive curves, just to be honest here. So in this cohort of patients with more advanced disease, systemic therapy really matter. We can argue the benefit of local therapy, but systemic therapy matter based on these results. Now, progression-free survival was also better for flood compared to cross. As you can see, here's the number, was statistically significant with a hazard ratio of 0.66. Now, looking at the pattern of failure, as you can see here, the isolated distant failure was significantly higher in cross. So 80 compared to 46, which is very expected. You pretty much did not give any systemic therapy. Local and distant failure was also higher, 29, 26. As you may see here, radiation cut the isolated local recurrence by 50%, even if the number of events is small, but still like 17 event in the flood compared to 9 in the cross. Comparing to hazard ratios compared to other studies, so as we mentioned, NEO-AGS was negative study, so they were equivalent between cross and ECF, which we know that MAGIC and cross pretty much comparable when you look at the results from both studies separately. Flood 4, flood did better with a hazard ratio of 0.7, similar to the current study with a hazard ratio of 0.7. Now, comparing our results from this study with other studies, as you can see here, that's 3-year overall survival. In the cross, initial cross was 54% compared to 51% in this study, and pretty much in the similar range of 50 to 57 among other studies. The pathologic complete response was much better in the cross, 23% compared to 10% in the you would think more modern study with better radiation delivery. You can argue that those are more advanced patients, more node positive, more T4 disease. That may explain why. But again, it's less than half what we have seen in the initial cross study when it came to pathologic complete response. And here are other data for comparing it to the other studies. So in conclusion, flood prolonged overall survival compared to cross in esophageal adenocarcinoma. Distant metastasis is the most important cause of this, which is less frequent after flood compared to cross. PET significantly impact and accuracy of staging. The study was done mostly in Europe and Germany, where insurance still does not cover for PET in esophageal cancer, and that's why many patients did not have PET scan in this study. Baseline PET scanning is mandatory, and actually the authors now are trying to reach out to the insurance bodies in Germany and try to improve the rules over there. And now we're presenting some future suggestion or perspectives. Replace carbotaxol with a more potent systemic chemotherapy might help, like FOLFOX, metabolic response to induction phase, and adjuvant immunotherapy after neoadjuvant chemoradiation and surgery. We already have data for nivolumab in this setting. I would add to this that is not here consideration of total neoadjuvant therapy with combination of both winning arm together, which kind of is standard now in our institution. They acknowledge the participating centers. And with that, thank you very much.
Thank you so much for this great presentation, and I'll open the floor for questions. But before that, I would like to ask Dr. Mohammed, maybe I missed this, but was there any subclassification for MSI status in the study that you presented?
And they actually don't look at any MSI status.
Yeah, I was waiting for this information, and I couldn't find it actually.
Unfortunately, they didn't actually look at MSI status at all.
Interesting. Maybe this is something
very
we need
interesting.
to
Actually, one of the things that they should really consider.
definitely, because we cannot treat rectal cancer now or even colon cancer without knowing MSI status for these patients. Questions? Yes. تفضل دكتور. Mike, please.
So thank you for the presentations. Just a question for Dr. Tamer. It's a very interesting study, right? You get the very best arm of systemic therapy proven, but the very worst arm from the original cross that we know the effect on adenocarcinoma is essentially nothing. And then you compare the two. So the result is not surprising, but my question is, when you, just in practice, when you compare perioperative clot versus high-dose chemoradiation, followed by adjuvant immunotherapy, as the New England Journal study showed, do you really think there's a clear indication to go with radiation emission in practice? Or do you feel that after the study and after these beautiful curves, radiation is dead and in the water?
So definitely this study created a lot of bad vibes in our tumor boards, right? So our colleagues in medical oncology now think that radiation should be dead in esophageal adenocarcinoma, that you cannot argue with these curves and you just should shut up and not even mention it, which we disagree. So as you mentioned, even in the initial cross, yes, the study mentioned 41.4, but you could go to 45 or 50.4. And talking to the PI who designed the study, Karen Goodman, and how she did in her practice, she never stopped at 41.4. So actually we consider 41.4 as a palliative dose that we give in most patients. What we do in our institution is that definitely squamous cell carcinoma is a different animal. So everybody get chemoradiation. When it comes to adenocarcinoma, it depends on, it's kind of individualized approach. So if it's like a patient that is similar to the main cohort in this study, very advanced local regional disease at a very high risk of distant mets, we should submit that perioperative chemotherapy should be the way to go unless they are symptomatic. So if he comes with complete obstruction, and we hate to place stents in these patients because we think eventually if they need radiation, it might cause perforation as well. So at this point, we would offer what we call aggressive palliation or chemoradiation followed by chemotherapy and then surgery if we can do that. It really depends on the case. If it's like a limited small adenocarcinoma that fits the protocol of the criteria of the initial cross, it is a discussion with the medical oncologist. I think if you look at the NCCN guidelines now, it allow both. It didn't go any to one way or another. That might change soon, but for now, it's still both options are valid. So I would say it is a patient-to-patient decision. I do not think radiation is failure. I have seen a few patients in other institutions like University of Chicago who never give radiation come to me after with a anastomotic recurrence, bleeding, and they need radiation. So I think local therapy is important. I think now we have better chemotherapy. Radiation should complement that. It should not be a competing situation. It should be a complementing situation.
Thank you, Professor. If you allow me as well, Mike there, please. I think the study clearly highlight the complexity of the GI cancers. I mean, it just a systemic disease and the failure of the radiation. It's not because of the local failure, but actually systemic failure because there was metastatic disease from the beginning. So this is something, we face in different cancers, including pancreatic cancer. Dr. Taha, until we get the mic, the Chinese study actually was very interesting. They selected the very high risk, the T4. They didn't even go with the T3. They went to T4 and the N disease. And I think this was a very smart move, trying to highlight the high risk, trying to prove maybe we can get some benefit. But where do you see the radiation in the adjuvant setting now? We're still debating this question now, since whatever, since when?
I agree with you. It's debatable, but maybe based on that last publication in like few weeks, with 300 patients, now there is some justification to give adjuvant radiation therapy in patients who had upfront surgery, D2 dissection, R0, and having more than 4 lymph node positive or lymph node positive that's outside the group of the epigastric lymph node. That's the only evidence that support that. Until we get the Top Gear answer or the Critic 2 answer, we get this as an evidence to give for high risk, very high risk patient. As you know, first they give it for D1 dissected patient, then said, no, we will give it for D2 and C. But then they said, okay, the enteric subtype and the positive node are high risk, give for them. It's not gonna work. It's not working until now, until that last publication. This is the only one that proved in a sensible way there is an advantage for disease-free survival for those patients with N2 or D2, positive nodes outside the perigastric node.
I do agree with that, but actually there's also, disagreement about this approach as well. Some will disagree that we're giving radiation. I do prefer giving radiation this setting, actually, especially with the heavy lymph node involvement. But again, this is a very, questionable gray area.
You are absolutely right. And actually, a radiation oncologist doesn't like giving post-operative.
Actually, you're right, because I always push my team and they keep saying no.
Actually, it's a nightmare. But this is, well, if you have very high risk patient and you have an evidence for that, you cannot deprive the patient from that evidence until we get the result of further studies.
Agree. تفضل.
A question for you, Professor Hamid, and to Professor Tamer. So if you have to redesign cross trial, let's say you are the medical oncologist, the PI medical oncologist, and you are the PI radiation oncologist, what things do you change from medical oncology chemotherapy regimen, and what do you change from radiotherapy?
The chemotherapy, again, I mean, the FLOT has been proven, to be the best approach. Dr. Salah Al-Batran, who's a good friend of mine, actually, he did a great job to design such a very brave, study, which has changed the way that we treat the upper GI cancers. So FLOT currently for me is the way to go. In fact, this morning I was counseling a patient, elderly in her 70s, and I had a very interesting discussion. They were asking me, will she be able to finish chemotherapy? And I was thinking, what number should I tell them? I told them, maybe half of the patient they will not be able to finish the treatment because again, it's toxic. It definitely will not be easy for her. But again, until we find another easier protocol or regimen, I think FLOT remains the standard of care.
So I agree about chemotherapy. I think FLOT remains the gold standard. If I am to redesign the study, and it is interesting because we are actually designing an investigator-initiated trial in our institution. I think the way to go is total neoadjuvant, similar to rectal cancer. I think we should start with systemic therapy if there is no obstruction, because the risk of distant mets is very high, and then rescan the patients. If they remain without evidence of metastatic disease by a PET scan, we should offer them chemoradiation with or without surgery to follow for organ preservation. This surgery comes with huge morbidity and mortality. I mean, mortality is not anymore, but morbidity is bad and quality of life sometimes is difficult. Plus, if you look at the data, the added value of surgery is debatable sometimes. And most of those patients are elderly, frail, they can't even go to surgery. So local therapy here is really important. Another criteria is like if the patient is not going to surgery because of their performance status, then you should give radiation as well. And they study there was surgery. So I would say total neoadjuvant is the way to go.
In fact, actually, I think we are moving more toward organ preservation in all disease sites. So the future actually is brighter. Doctor.
And you will raise the dose of the radiation therapy.
Someone has the mic.
Yes, thank you for the excellent talks. Actually, a very informative discussion and answers a portion of my question. I do have a question for you, Professor. Has there been can you comment on efforts in adding radiotherapy to the FLOT regimen? Is there any publications looking into that?
No, concurrent, no, we did not, or even like sequential. I don't think, I am not aware of any for now, not yet. Yeah.
I was just going to make a comment about the higher dose of radiotherapy. Do you think that would still make a difference if the single biggest difference between the two arms was actually isolated distant disease? So given more radiotherapy locally, would that make a difference?
You're losing systemic control.
Exactly.
So that's a good point. I do not think it will matter. Actually, it might be harmful, as we know the data from our prior studies. But 41.4 is still a very low dose. So our standard is 45 gray, and then boosting the gross disease to 50.4. I think 50.4 will give durable response. Remember, these are early data too, right? The last patient was randomized 2020. This was presented 2024, which means they started the analysis 2023. So even this 5-year data, I don't believe it, just like, a statistical track. So, but I think 50.4.
Any one last question before coffee break? نسمعك دكتور، مو مشكلة.
شكرا للpresenters بس أنا I want to clarify something. The colleagues from Germany, this was a history. They have in DIGRO is in Deutschland, it's the radiation oncology in Germany. Two groups, one prefer to do radiotherapy with cross, and the other group doesn't prefer to do the radiotherapy with adenocarcinoma. So they have challenged these two groups. This study, all of them are radiation oncologists. You know, this is not a medical oncologist. Yeah? Professor Baus, this is my investigator. So they have found, this is in the tumor conference, that the adenocarcinoma is always an argument with medical oncologists and radiation oncologists if we do it with like cross or not. So they do this comparison, as was upset for the first group. If we do certainly radiation add something to this group or not, we know that adenocarcinoma is also a systemic disease. So radiotherapy to float or radiotherapy as cross doesn't make difference. It's in NCCN guidelines, and the guidelines in Germany since 10 years, they don't auch do radiotherapy by adenocarcinoma. So this study, 2024 money, they have an argument, and now 2025 in guidelines in Germany, they have said, don't give radiotherapy to adenocarcinoma. So I know the only small comment that the group is radiation oncologist. There's no way to prove radiotherapy brings something to adenocarcinoma or not. Thank you very much.
Thank you. I mean, definitely Germany has a lot to do with the GI cancer, the rectal, and changing the way we practice. So thank you for the historical perspective, and we'll take 10 minutes break, then come back. Thank you so much.
بقول لك ليش ما اعطيك كان عندك في اوبشن
لا
Good evening, everyone. So I think we're ready to start the next session. It's getting already late, we're already delayed. I'm Dr. Yasser Hassan. I'm the chairman of Radiation Oncology Department at the Kuwait Cancer Control Center, and have the privilege to be have my colleague Dr. Adnan moderating the session as well. So I think we're going to start off with a talk by Dr. Majid Al-Ghamdi. He's the head of SARO and chairing the sessions, the conference, and the event we have nowadays in the coming few days. And he's a consultant radiation oncologist. And to address the topic on multi-institutional study of the impact of re-radiation dose for recurrent high-grade glioma. You can come up.
Thank you, Dr. Yasser and Dr. Adnan for chairing this session. Thank you, Dr. Muhammad, for your kind invitation. It seems that the gynotherapy, the brachytherapy workshop is more attractive to many people. So just for those who do not know, we have a parallel session, hands-on brachytherapy session that will finish today. So tomorrow we won't have that. So hopefully we'll focus on the main program. So my talk today is about a multi-institutional study of the impact of free radiation dose for recurrent high-grade glioma. So these are the disclosures of the authors. So this study was, it's multi-institutional led by City of Hope Hospital in the United States, Dr. Lee. So we know that the radiation for recurrent high-grade glioma is an accepted treatment option. The ideal patient selection factors, dose and fractionation scheme are unclear. Re-radiation doses are frequently limited by the concerns of severe neurologic toxicity. We commonly use a regimen of 35 gray in 10 fractions that was shown to improve progression-free survival without overall survival benefit in the only recurrent glioblastoma RTOG trial, RTOG 1202. So this study was a retrospective review of patients undergoing fractionated re-radiation for high-grade glioma and was conducted across 12 academic institutions in the States. The high-dose re-radiation was defined as 47.25 gray BED 10, which is equivalent to the most common re-radiation dose of 35 gray in 10 fractions. Kaplan-Meier method was used to estimate the overall survival. Cook's proportional hazards regression models were used to identify factors associated with overall survival, and toxicity outcomes were assessed with logistic regression. So they included a pretty good number for such studies. 482 patients were identified, and the median dose at re-radiation was 47 gray BED 10, with the range from 47 to 53 gray BED 10. The median Kaplan-Meier, the median KPS was 880, so pretty good performance patients. And the most common dose for fractionation at re-radiation was 35 gray in 10 fractions. So these are the demographics of the patient. About 30% of them had IDH mutation, and about half of them had MGMT methylation. And many of them actually received concurrent temozolomide or bevacizumab. So the two categories of doses were found and examined. The low dose, which is 35 gray in 10 fractions, 37.5 in 15 fractions, or 36 in 20 fractions. Those were called low-grade category doses, and the high-grade category includes a 45 gray in 25 fractions, 40.5 gray in 15 fraction, and 50.4 gray in 28 fractions. The median overall survival for the cohort was 9.8 months. 1 year overall survival was about 40%. The benefit in overall survival was seen with dose higher than 47.25 gray BED 10, with a hazard ratio of almost 0.6 and significant p-value. Other predictive factors in multivariate analysis was glioblastoma histology, tumor diameter more than 5 centimeter, and less than 12 months between the radiation courses, as well as increasing number of recurrences. So as you can see on this graph here, the green is a high dose patient, and the blue dotted line is the low dose patient. So those who actually received high dose re-radiation, they did much better in terms of the survival and the progression-free survival. And they actually looked at the molecular subtypes, and it showed some interesting findings. So there was a benefit in the benefit in overall survival with dose escalation was seen in tumors with and without MGMT. However, it was much more seen in, or much more significant in those with methylated MGMT tumors. So among those with MGMT methylated tumors, the median overall survival was 13 compared to 6.5 months. So much more with the high dose as compared to the low dose radiation. But the same thing was seen in the MGMT unmethylated tumors. So the high dose was effective compared to low dose across the all type of tumor, but much more when you have a MGMT methylation. Pretty much the same thing was seen with the IDH mutation. So those with IDH mutation, they had more pronounced positive impact of high dose re-radiation compared to the low dose, with overall survival, median overall survival 21.3 versus 11.3 in those with IDH mutation, and 10 months compared to 6.5 months in those with wild type MGMT. So the highest hazard ratio for overall survival was found at doses more than 59.47 gray BED 10, which is equivalent to re-radiation dose of 50.4 gray in 28 fractions, which we typically give, or which typically use in a good performance patient, relatively young, so which we call pretty much full dose re-radiation. The lowest p-value was seen at 48 gray BED 10. So 50.4 gray in 28 fractions and 35 gray in 10 fractions deliver similar dose to normal CNS tissue. So with those who had more or higher dose at re-radiation, they had the same dose in terms of BED when you consider alpha beta ratio of 2 to normal tissue. So which means that, and this is what they observed as well, that those patients, when they compared both groups in terms of the toxicity, high dose and low dose re-radiation, they both they did the same in terms of this, in terms of toxicity. So which means that the you can deliver high dose, you expect same toxicity as low dose, but much more benefit in terms of the survival and probably local control as well. So the result, what they found is about 100 patients developed grade 2 or greater. Those who received bevacizumab received dose escalation, and GTV size more than 5 centimeter was not associated with development of grade 2 or greater adverse event. So even with bevacizumab with high dose escalation and big tumors, the toxicity was similar to the groups who are much more favorable in terms of those prognostic factors. And then no other factors were predicted for grade 2 or greater. So pretty much toxicity was the same in terms of the result. So in conclusion, the use of doses greater than 35 gray in 10 fractions, which is the most commonly used at the moment, dose of radiation, for recurrent high-grade glioma was associated with improved overall survival benefit. With a benefit to dose escalation was seen in all molecular subtype groups, And the benefit was exceptionally large in IDH mutant and IDH methylated tumors. And dose escalation to 50.4 and 28 fractions may be ideal for IDH mutant tumors with good KPS. Increased irradiation dose was not associated with increased grade 2 or higher toxicities. And the factors that guide selection of the patient for re-radiation include non-glioblastoma histology, GTV less than 5 centimeter, a small number of recurrences prior to the re-radiation, and at least 12 months between the RT courses. So with that, I conclude the talk, and thank you very much.
Thank you, Dr. Majid Al-Ghamdi. Next speaker, Dr. Saif Al-Jabab. He's an assistant professor at King Saud University. He's the chairman of radiation therapy department. He's going to talk about neurocognitive outcome of conformal whole brain radiation therapy with bilateral unilateral hippocampal avoidance plus memantine for brain metastasis, phase 2 single-blind randomized trial. Please.
Okay, thank you very much. I'd like to thank the organizing committee for inviting me. I'd like to welcome all our overseas visitors. Welcome to Saudi Arabia. Hope you enjoy your visit. Nothing to disclose in this talk. This is a phase 2 study done in Taiwan, looking into hippocampal avoidance during whole brain radiotherapy. So just some historical context. We've had 2 publications all in the early of the decade here. One looked at the neurocognitive function with hippocampal avoidance and whole brain radiotherapy, looking at the raw scores of memory, and showed that there was significant improvement with hippocampus avoidance with whole brain radiotherapy versus whole brain radiotherapy without any hippocampal avoidance at 6 months. Similarly, we had another publication looking at memantine, the use of memantine with hippocampal avoidance, which in turn also showed that there was improvement in neurocognition when used together. This is a scatter plot looking at some of the more historical studies looking at left versus right-sided hippocampus effect on neurocognition. They found that there was, more pronounced loss of neurocognition associated with the left-sided hippocampus compared to the right side, and that radiation doses to the left hippocampus had a much more greater impact on neurocognition than on the right side. And you can see that in the diversion of the curves. So the hypothesis and goal of the study, the hypothesis was that bilateral hippocampal avoidance whole brain radiotherapy preserves neurocognitive function compared to whole brain radiotherapy. The right and left hippocampus exert different neurocognitive functions, and radiation dose to the left hippocampus may be more related to neurocognitive impairment following whole brain radiotherapy. So the question asked in this trial is, could unilateral left-sided hippocampal avoidance provide an equivalent neurocognitive preservation as bilateral hippocampal avoidance? So the study, the eligibility were patients who had brain metastasis outside of the hippocampus area, at least 5 millimeter margins, patients who are above the age of 20 with good performance status, and a life expectancy above 6 months. And there was an additional layer here because a lot of these patients do receive stereotactic radiosurgery, is that no more than 5 lesions were treated with SRS. So this was a single-blinded randomized phase 2 study. And during the randomization, they randomized to 2 arms. One arm simply looked at bilateral hippocampal avoidance, the other only in unilateral, specifically the left side. And the dose regimen used in the US is 30 gray in 10 fractions. And I think that's what they use here in this Taiwanese study. So the primary endpoint was looking at the decline in the Hopkins learning test at baseline, from baseline to 6 months. And then there were some secondary objectives, including neurocognitive function, the trail making test, and some of the other quality of life metrics. The hypothesis testing used a one-sided equivalent design, and the sample size was targeted at 72, so relatively small study. The technique, hopefully it's clear here. So the right side, your right side, is the bilateral hippocampal avoidance compared to the left side. You'd note in the DVH that they were able to achieve a lower mean dose to the left hippocampus when trying to spare only one side versus when they tried to spare both at the same time. In terms of the both groups were pretty balanced. There was no any statistical difference between both groups in terms of baseline characteristics. Similarly, there was no any major difference between the demographic data in terms of education. Note that most of these patients did have lung cancer in both arms, and they both had no significant grade 3 or higher toxicity. Their baseline neurocognition was pretty much similar, nothing significant in terms of difference between the both groups in terms of the baseline recall tests and neurocognitive tests. And these are the results. So at 6 months, they had about 20 patients in the unilateral unilateral avoidance arm compared to 24 patients. And they found that there was practically no significant difference between both groups. You can see through all the different kind of tests that were done for the patients that the neurocognition was very similar between both groups. So whether you spared both sides or one side, the neurocognitive outcome was similar. The secondary objectives, they looked at overall survival and progression-free survival. Basically, none of them were significant. One important thing to note is that there were 2 hippocampal failures, so recurrences within the hippocampi, one in both arms. So in summary, unilateral left-sided hippocampal avoidance can equivocally preserve neurocognition in patients who receive whole brain radiotherapy compared to those receiving bilateral hippocampal avoidance. So lower doses to the left hippocampus for patients, there's a trend that might be similar to bilateral and that did not necessarily affect clinical outcomes. That's the end of my talk. Thank you very much.
Thank you very much, Dr. Jabab, for the excellent presentation. Next speaker, Dr. Huda Attouhi, Associate or Assistant Professor at King Abdulaziz University Hospital, Radiation Oncology Consultant. She's going to talk about evaluating neurocognitive recovery following stereotactic radiosurgery and whole brain radiation therapy, insights from pooled analysis of 3 phase 3 trial.
Thank you. Hello, everyone. Thank you for having me here. So as Dr. Al-Hibshi mentioned, my talk will be evaluating neurocognitive recovery following stereotactic radiosurgery and whole brain radiation therapy. So just as a review, there are several trials that looked at the cognitive failure in terms of comparing SRS with whole brain radiation therapy. The first one was the NCCTG trial and compared SRS with whole brain, and they looked at cognitive failure as a primary endpoint. They had 1 out of 6 tests, and any patients who failed in any of them would consider to have cognitive failure. They also had another endpoint, a secondary endpoint, in which they looked at cognitive deterioration-free survival, and that was also significantly better with patients who underwent SRS versus whole brain. And then we have another NCCTG trial that they looked at SRS versus patients who underwent whole brain and then an SRS boost. They had the same definition of cognitive failure, and they saw that cognitive failure at 3 months was significantly greater in patients who underwent the whole brain with the SRS versus the SRS arm alone. Here we have the hippocampal avoidance trial. It was significantly better in patients who underwent the localized radiation with the hippocampal avoidance in compared to the patients who underwent the whole brain radiation alone. So what they did here, they looked at the 3 randomized controlled trials that were concluded, and including all patients who underwent the neurocognitive failure as a predefined term in each trial. They did a meta-analysis with fixed effects model performed, and they looked at full cognitive recovery. And their definition was any patients who no longer exhibited 1 or more SD decline from baseline on any of the cognitive tests. Also, recovery on individual tests was defined as at least 1 SD improvement on any previously failed cognitive tests. Cumulative incidence function and GRACE tests were used to estimate incidence of cognitive recovery. Prognostic variables associated with cognitive recovery were assessed using multivariable Cox proportional hazards modeling. So here in the pooled analysis, they looked at 288 patients who experienced the trial-defined neurocognitive function, and full cognitive recovery was found in 38% and 42% at 6 and 12 months after the onset of neurocognitive failure. In here, they looked at patients individually, so SRS patients versus the whole brain. And we can see that the blue graph shows the patients who underwent the localized radiation, and they did much better in terms of cognitive recovery. Also here with the hippocampal avoidance, patients who underwent the hippocampal avoidance, there was a significant increase in the incidence of the cognitive recovery. Here they looked at the prognostic factors associated with the cognitive recovery, and SRS showed a significantly higher likelihood of cognitive recovery compared to whole brain patients with a p-value less than 0.001. With the hippocampal avoidance patients, there was also a trend towards an increased rate of cognitive recovery compared to the whole brain patients. Here they looked at each trial individually, and we can see much better results with the two trials that looked at SRS patients in terms of cognitive recovery. What about post the cognitive recovery? They looked at the patients after that, and they followed up the patients, and 65 patients had cognitive testing data beyond their cognitive recovery, and roughly 2/3 of those patients demonstrated a sustained cognition. So in conclusion, this is the first description of a novel concept of cognitive recovery defined as the absence of cognitive failure, no longer exhibiting 1 or more SD decline from baseline on any cognitive tests. Their analysis revealed that around 40% of patients who experienced neurocognitive failure initially following brain radiation therapy eventually demonstrate full cognitive recovery. Nearly 2/3 of patients with longer-term cognitive testing data maintained their cognitive recovery. At the individual trial level and on pooled meta-analysis, a conformal radiation therapy, whether it was SRS or hippocampal avoidance, compared to the conventional whole brain radiation therapy, shows a substantial benefit with regards to cognitive recovery. These findings may help counsel patients about their likelihood of meaningful cognitive improvement after radiation and underscore that neurocognitive decline is not necessarily a permanent condition, which may also affect the clinical trial design. Thank you so much.
Thank you very much, Dr. Huda, for a very interesting topic, very valuable as well. Our next talk, we have Dr. Huwaij Al-Mukhlis. I think it's a virtual talk, actually. And Dr. Huwaij is a consultant radiation oncologist and head of radiation oncology at Prince Sultan Oncology Center in Tabuk. The topic will be target volume delineation for the reirradiation of recurrent glioblastoma, MRI, or PET-based results of the GLIA prospective randomized trial. So whenever we have the speaker ready as a virtual talk, we can get started.
Thank you very much. Just give me a minute. Hello.
Dr. Huwaij, we can hear you.
You can hear me?
Yes, yes, we can hear you very well. We can see you very well. And I think we have the slides on display as well, or it's coming up.
No. It's going to
So if you just go back to the beginning of the presentation.
Thank you very much for this opportunity. First of all, we know that all of us are radiation oncologists. We have a very big challenge for re-irradiation of recurrent glioblastoma. When we treat which volume we can treat, and the images we can use to confirm there is a recurrence or there is a necrosis. This study is a German study, this disclosure. It is evaluation, study objectives, evaluation of value of amino acid PET versus contrast enhancement T1 MRI to support target volume contouring for high precision radiotherapy radiation of recurrence glioblastoma. The study design, it is a prospective phase 2 randomized trial where 1-to-1 randomized between experimental arm, which is amino acid PET GTV gross tumor volume according to PET amino acid PET, and the control arm, which is contrast enhanced T1 MRI, the same CTV and BTV for the two arms. And the inclusion and exclusion criteria, recurrence glioblastoma on MRI and PET, not operated or with residual tumor after surgery, histologically confirmed glioblastoma at initial diagnosis or at relapse, pre-irradiation 60 gray, and at least 6 months between pre-irradiation and randomization. Recurrence can be defined on contrast enhanced T1 MRI or amino acid PET with the maximum diameter 1 to 6 centimeter. And target volume definition and planning possible using contrast enhanced T1 MRI and amino acid PET. Start re-irradiation with a maximum of 2 weeks after amino acid PET and MRI. Exclusion criteria, therapy with avastin or target therapy less than 6 months, and surgery less than 3 weeks, and treatment based on MRI or amino acid PET not possible. This is the flow chart. Flow chart started with screening with MRI and amino acid PET, both showing lesion, then randomization between the experimental arm and the T1 GADO MRI, which given the same dose, 39 and 13 fraction. Then after that, the follow-up within 6 weeks after the end of radiation. Then after that, every 3 months. Any suspicion of any time after radiation indicated in case of suspicion of progression or recurrence or radionecrosis and MRI. They are followed by amino acid PET. After that, in the clinical follow-up and radiotherapy, they looking for radiotherapy toxicity and serious adverse events. And follow-up after radiation, the radiotherapy toxicity and serious adverse events of relationship to radiotherapy after 30 days, or serious events related to radiotherapy until end of follow-up. The primary endpoint for this study, it is progression-free survival, defined from the day of randomization to the day of tumor progression based on MRI confirmed by amino acid PET and or positive biopsy surgery, or the day of death of any cause. Negative PET scan exclude progression, while a positive PET, if unclear, was followed by biopsy. Patient receiving any new systemic tumor treatment other than pre-planned chemotherapy for their recurrence glioblastoma in the absence of diagnosed tumor progression. Patient receiving surgery for a distance progression. Patient receiving Avastin were considered as having an event for the end point progression-free survival. Then tumor progression was divided as local or distance progression. Local in the field of treatment for radiation, and distant progression, it's not in the field of the radiation. Secondary endpoint in the study of survival, local control, and volumetric analysis of GTV, MRI, and PET. Progression pattern topography of recurrence after radiation, evaluation of patient with long-term survival, toxicity, and role of amino acid PET and the diagnosis of radiation necrosis, then quality of life, and role of diffusion, perfusion, weighted MRI in comparison with amino acids. PET. Participating center, 14 center, Germany center. The study was registered at Federal Institute of Drug and Medical Device, and the 18th amino acid fat tracer was manufactured at the University Medical Center in Germany, and the evaluation of pharmacovigilance was an important endpoint of the study. This is the demographic data where there is no big difference, or there is no difference between the two arms, either for gender or the MGMT status, or the chemotherapy for treatment, or the option to the chemotherapy for treatment, or the MGMT status. The result, there is no difference between the two arms for the progression-free survival, and also for overall survival, there is no difference between the two arms, and for the locally controlled survival, there is no difference also. But for volumic assessment, which I have seen here in the study, there is a big difference in the non-overlap GTV, about 10 millimeter between the two arms. And the overlap volume about 5.4 millimeter. This is one of their patient which was treated by on the MRI. This is the area of recurrence. Then he's treated on the recurrence. Then this is the result after 6 months, which showed there is a necrosis in the area of re-irradiation. The toxicity which showed there is no difference between the two studies. There is a lot of grade 3, 4, 7 patient in PET arm and 4 patient in MRI arm. Most of the toxicity are neurological toxicity, focal seizure or generalized hemiparesis, and cognitive impairment, headache and fatigue, or leukoencephalopathy. The toxicity impact of radiation necrosis would show that there is a positive effect of radiation necrosis on overall survival is higher than the negative effect of tumor progression on overall survival and persist independently of tumor progression. Median overall survival 12 months versus 8 months in patient with versus without radionecrosis. The conclusion, this is the first randomized study to compare two imaging modality, amino acid PET and contrast enhanced MRI T1 to delineate the target volume for radiation treatment planning in GBM. The study show in 200 evaluated patients that both imaging modality are equivalent for the re-irradiation of recurrence glioblastoma. Therefore, in this case, one of the two modality could be chosen for determine the target volume. Stereotactic re-irradiation with 39 gray and 3 gray fraction was shown to be a safe and effective treatment option for recurrent glioblastoma. Patients who have developed radiation necrosis have a significantly better outcome. The patient cohort who had received the FET tracer was defined as the pharmacovigilance population. The evaluation was carried out in the entire cohort. The FET examination and in the particular the FET application have proven to be safe. I have something to say here. You hear me or not? Hello?
Yes, we can hear you, Dr. Hoyt.
Okay. Myself, I analyzed the article and I found there is some strong strength in this article. It's the first multi-centric randomization designed, first randomized phase 2 trial assisting imaging impact on the survival outcome in the recurrent glioblastoma. And it is centralized quality assurance with review committee, nuclear radiation oncology physics, and PET scanner harmonization via phantom study. Well-defined endpoint with PFS as primary endpoint, and with multiple clinically relevant secondary outcome like overall survival, toxicity, local control, and a realistic clinical model focus on re-irradiation of recurrent glioblastoma. But there is a weakness in the study for me. It is phase 2, not powered for definitive efficacy. That means study may not conclusively prove superiority. Phase 3 maybe confirmation needed. And it is open label design. No blinding could introduce bias and subjective endpoint. Limited histological validation. PET interpretation viability. It is visual adjustment. Introduce radar dependency. For a clinical implication for this study, amino acid PET based delineation can potentially improve that can decrease the toxicity by minimizing irradiation on non-tumoral tissue. And
please conclude, Dr. Hoyt, in 2 minutes, because your time is.
Okay, technical implication, we can improve GTV delineation. Treatment planning evaluation, we can promote it also. Potential for broader oncology application, and guide standardized of PET protocol. Maybe you can use it also for the newly diagnosed glioblastoma. Thank you very much.
Thank you very much. It was a really interesting session. If anybody have any question, I will start with that question. Actually, in the past, I'm very old, by the way. Don't look at. I'm an old generation of radiation oncologist. Radiation therapy to the whole brain was insulted that it affect the neurocognitive function. We agree. In the past, they used to have a mini-mantle test. It's a very special test for cognitive function. Once they saw that the recovery of the cognitive function after the whole brain radiation therapy, I'm talking about 30 gray in 10 fractions. Oh, there is improvement in the cognitive function to normal. All of a sudden, from nowhere, verbal learning test, Hopkins verbal learning came to the, so there is a different tool to measure the cognitive function. So everybody said, oh, but the Hopkins verbal learning test showed that the cognitive function not improved. And they want everybody to avoid the whole brain radiation therapy, which is the cheapest, the easiest, and it's not time consuming for the radiation oncologist. It can be done within a second. Anybody, the junior resident can do the whole brain radiation therapy. Now they are talking about the improvement in the cognitive function after whole brain radiation therapy with the Hopkins verbal learning test. So who presented the cognitive? Dr. Tohi, yes. So what's your comment about this? Changing the yardstick of measuring the cognitive function during the era. Aoyama, for example, from Japan, he did compare between the stereotactic and whole brain radiation therapy, and they found that patient from another metastasis, because the probability of another metastasis in brain within 3 months is a 50%. Whole brain radiation therapy will decrease that. And he insulted the another metastasis which can cause decrease in the cognitive function.
Actually, what they showed was that whole brain was worse in terms of cognitive failure and in terms of cognitive recovery when compared with either the hippocampal avoidance or with the SRS. None of the tests that they did that showed that patients who underwent the whole brain radiation recovered well. So maybe you disagree. I think you have more experience with that, but I don't know. Since I started my training, I was told that whole brain is the worst. And also all of the patients are afraid of it now. So I personally try to avoid it as much as possible, to be honest.
So this is a pooled analysis of 3 landmark control trials, all done by Paul Brown, who's the godfather of stereotactic radiation therapy and metastatic disease to the brain. And as one of my senior colleagues used to say from Princess Margaret, if you have a single or a few lesions in the vertebra, in the vertebral column, you don't treat the entire vertebral column. So why do you do that for the brain? So whenever you have disease, you target the disease and treat the disease of concern. And this is what we're seeing here, utilization of technology in our field that improves patient outcomes, cognitive function, cognitive preservation, without, of course, affecting disease control outcomes. And that's a key feature here. We can take more questions. I think there's very interesting topics presented today.
Thank you very much. I have a question. What's your cutoff of a number of METs in a brain to use whole brain? So you have said that's the spinal cord we treat no every single lesion, but it's different tema. Spinal cord is a completely palliative. It depends on patients have symptoms, neurological symptoms, and so on. When we are talking about brain METs, what's cutoff for numbers? In Germany, we have used 10, not 4 anymore. 10, we use SRS. More than 10, we use whole brain. And the second question, do you mean that as when the patient, your colleague said that I told the patient or the patient are afraid from the whole brain, but we should have told the patients how many METs do you have in your brain? Do you have a single lesion, 4 lesions, or multiple supra, infratentorials? Must make a difference. So it's very completed. We can't use one-to-one And SRS techniques is very complicated for more than 10 lesions. This is first, excuse me, so I want to ask us the second one. For GBM, I don't know what is the GBM criteria here. Here in medicine, we have used for all GBM is the MGMT negative or MGMT positive. For negative, we use a standard chemo for Timodal. For positive, we used always CCNU with Timodal with TTF. This is standard now since 2024. It's in guidelines in Germany. So did they make a difference? Overall survival, 24 months versus 12 or 11 months without TTF. So the recurrence for this study in Germany also, we have used now as a standard Fitbit, but it's very expensive. And this was used to differentiate, is this a truly recurrence or a pseudo recurrence? And they have done a serial of biopsies to improve it. Is this a truly recurrent with a contrast image MRI T1, or is this a Fitbit negative? So the second question is, why we don't use the pulsatile reduced radiotherapy by recurrence instead of stereotactic radiotherapy? And the stereotactic radiotherapy depends on ice doses. I don't know what do you have ice dose. Is an 80% or 100%? Thank you very much, and sorry for letting.
It's Dr. Abdelhaim will be angry if we proceed. Thank you very much. It is the end of our session.
Thank you for your kind introduction. I will be discussing interim futility results of NRG-HN005, which was a randomized.
And now we'll move on to the head and neck session, and that's going to be moderated by Dr. Ali Husni, Associate Professor of Radiation Oncology at University of Toronto, Princess Margaret Hospital, and Dr. Ahmed Boushehri, oncologist from Kuwait.
Oh, thanks very much for the invitation to be here for the organizing committee, and probably because we are late, so let's start with our first presentation. Dr. Isa Mohammed from KHCC in Jordan, speaking about the interim fertility results of the NRG-HN005, a randomized phase 2/3 non-inferiority trial for non-smoking B16 positive oropharyngeal cancer patients. Dr. Isa, floor is yours.
Thank you for your kind introduction. I will be discussing interim futility results of NRG-HN005, which was a randomized phase 2/3 non-inferiority trial for non-smoking B16 positive oropharyngeal cancer patients, as previously presented by Dr. Yom at the latest Astro conference. This slide presents Dr. Yom's disclosures. As a background of this study, in the US, approximately 70% of newly diagnosed oropharyngeal cancer patients are likely driven from an HPV positive etiology. In this population, which have good prognosis and excellent long-term clinical outcomes, their long survival times raise a concern regarding late sequelae of concomitant chemoradiation therapy. HN002 was a randomized phase 2 NRG oncology clinical trial that evaluated the randomization of 60 gray with or without concomitant cisplatin. This trial previously presented at Astro, and the arm containing 60 gray with cisplatin met the acceptability benchmark to continue further testing with phase 3 clinical trial. This slide shows the clinical trial design of the NRG HN005, which was a phase 2/3 randomized study comparing each of two experimental arms against a control arm from R2G 1016. The primary endpoint for phase 2 was non-inferiority of a progression-free survival, while the phase 3 trial would continue if one or both experimental arms from phase 2 were not eliminated, with intended phase 3 co-primary endpoints of non-inferiority, progression-free survival, and superiority quality of life. This is the schema from the phase 2 of NRG HN005. Patients were considered eligible if they had B16 positive oropharynx SCC, if they had 10 or less back year history of smoking, if they had T1, T2, N1, M0, or T3, N0, N1, M0 according to the 8th edition AGCC staging system. Then patients were stratified by performance status and equally randomized between the control and the two experimental arms. Arm 1 was the control arm, included 7 degree of radiation treatment delivered in accelerated fashion over 6 weeks, concurrently with 2 cycles of high-dose cisplatin given every 3 weeks during radiation treatment. Arm 2 was the first experimental arm, included 6 degree of radiation delivered over 6 weeks with the same chemo high-dose cisplatin delivered Q3 weeks during radiation treatment, while Arm 3 was also accelerated radiation with 6 gray delivered over 5 weeks with nivolumab given before, during, and after radiation treatment. The statistical plan was based on non-inferiority with an estimated 9-month BFS of 96.5% and the lower threshold for experimental arms of 91.8% with an absolute non-inferiority margin of 4.7%, which led to hazard ratio boundary of less than 2.4 would required for non-inferiority. With one-sided type 1 error rate of 10% per test and 80% power, a log-rank test required 22 events from 266 patients per comparison. In phase 2, for each comparison, a futility analysis would trigger when 50% of the BFS events were reported. This is the phase 2 accrual, and as you can see, the trial did accrue during COVID-19 pandemic, and despite that, and despite termination of the arm 2, the trial accrued at near projection rate. Here is the total phase 2 accrual by arm, and as you can see, arm 2 was stopped early and did not recruit until its full projection, and the authors reported on full recruitment rate of arm 1 and arm 3. Patient characteristics on those enrolled and analyzed. The median age was 60 years, 91% were male, 88 were white, 85 had stage 1 disease, and 79 were never smokers. Protocol compliance was good. As you can see, 85 to 94% had radiotherapy per protocol or within acceptable variation. And if you look at the 3 arms, you can see that no radiotherapy due to withdrawal or refusal. was numerically different, 8.8% in the first arm, while 6.1% in the third arm. And if you look at the unilateral versus bilateral nuclear radiation therapy, in the controlled arm, 12.2% received unilateral radiation, while 17.9% received unilateral in the second arm, and approximately 10% received unilateral radiation in the third arm. Protocol compliance with systemic therapy was approximately 85% across all arms and was terminated per protocol conditions. So the first futility analysis was conducted after 11 progression-free survival events between arm 1 and arm 2. As you can see, arm 1 had 2 events, while arm 2 had 9 events. And at the median follow-up of 1.1 years with an estimated hazard ratio of 4.34%, the accrual was suspended for arm 2, and arm 2 was removed from protocol, after which randomization continued with 1:1 to arm 1 and arm 3 to complete the new phase 2 sample size of 382 patients. With a median follow-up of 1.7 years, the second futility analysis was triggered after 11 progression-free survival events occurred in arm 1 and arm 3. As you can see, arm 1 had 2 events, while arm 3 had 9 events. This led to an estimated hazard ratio of 4.51. And according to the study protocol, accrual would have stopped per protocol, but phase 2 had already completed. With the median follow-up of 2.2 years, the 2-year BFS estimates are 98.1% for arm 1, 88.6% for arm 2, and 90.3% for arm 3. The 2-year loco-regional failure estimates are 0% for arm 1, 6.5% for arm 2, and 5% for arm 3. And the 2-year overall survival estimates are 99% for arm 1, 98% for arm 2, and 96.1% for arm 3. So what can we learn from this trial? Is that the NRG R2G1016 regimen, arm 1 showed an impressive, outstanding result demonstrating a 98% progression-free survival rate through 2+ years. And actually, this is higher than any previous US result in this population, emphasizing that these patients are accrued at very high rates with a traditional concomitant chemoradiation therapy. The increase in transoral robotic surgery may have subtly shifted the enrolled population toward laser operability, which is a negative prognostic factor. However, the intensification studies must evolve to be more selective and effective if they are to be competitive in a more challenging population. Also, we learned that while the intensified radiation regimens work well in the large majority of these patients, current eligibility criteria are not selective enough. So we need for further enhancement of selection mechanisms, whether at entry or while on treatment. Another important point, bottom line, the largest rate of cure now documented in the national trial literature comes from NRG HN005. Phase 2 trials are not valid until evaluated or tested against a contemporary standard of care. These results set a new benchmark for progression-free survival expectations in this population. However, further de-intensification trials should be held to this very high standard going forward. This slide presents the author's acknowledgements. So here I will stop. So thank you for your attention.
So thank you, Dr. Isa. Our next speaker is Dr. Mohammed Al-Dahaim. He's known to everyone here. He will walk us through the trial looked into radiotherapy target volume delineation based on post-induction chemotherapy, gross tumor volume versus pre-induction volume for local regionally advanced nasopharyngeal cancer. So, Dr. Mohammed.
Thank you, Ahmed. So I'm going to present this interesting presentation. Came from China, where the nasopharyngeal cancer is endemic, and most now of our expertise come from that part of the world. So this is a phase 3 randomized trial. The reduced volume radiotherapy compared to the conventional volume radiotherapy after induction chemotherapy, and it was a non-inferiority multi-center randomized phase 3 trial from Guangzhou. So the author has nothing to disclose. And we know that the standard of care in locally advanced nasopharyngeal cancer is the induction chemotherapy. And as this is stated by the NCCN guideline, considered to be now category 1 after a long debate in the past. And estimated that luckily that the nasopharyngeal cancer is a chemosensitive and very radiosensitive disease, so that 90% of the nasopharyngeal cancer will respond to the induction chemotherapy. And still that the current recommendation is the full radical dose that you need to cover the pre-chemo volume is still recommended as per the international consensus guideline that published in the green journals. However, with that, this is associated with high dose exposure to the surrounding organ at risk. And with that, there is associated toxicity like dry mouth, hearing impairment, endocrinopathy, dysphagia, temporal lobe necrosis. So the author hypothesized that in the patients with locally advanced nasopharyngeal cancer responded to the induction chemotherapy, they can safely do reduced volume radiotherapy, and that will be non-inferior to the conventional volume radiotherapy with similar survival. And this is going to be associated with the reduced toxicity as well as improved quality of life. So this is the trial schema with the local advanced nasopharyngeal cancer. They treat them with the standard of care with 3 cycles of cisplatin gemcitabine as induction chemo. And then they will randomize them 1-to-1 fashion into the conventional, into the standard of care, which is shown in green, the conventional volume radiotherapy. That means they will treat all the pre-induction chemo volume. And then they will, the test arm is when they'd like to reduce the volume radiotherapy to the post-induction MRI scan. But all patients will receive concurrent cisplatin every 3 weeks, 2 cycles, with dose of 100 milligram per square meter. And the radiotherapy will be 66 to 70 gray in 30 to 33 fractions once daily, 5 times a week. Here's an example of patients presented with choana invasions, how the patient's going to be treated if they randomize into the pre-induction chemotherapy. So I can see on your left side, so if the patient randomized into the pre-induction chemo volume, they're still going to treat the choana compared if the patients got randomized into the post-induction arm, where they will spare the choana from including them in their GTV. Similarly, if the parapharyngeal muscle got invaded, if patients randomized into the conventional arm, they will still include it as part of their GTV, compared if the patients got randomized into the post-induction chemotherapy, then they will spare the muscle. However, the only difference is that the bone. If the bone involved, regardless the patients randomized to, they will still going to cover the bone fully as their GTV. And for the cervical lymph node metastasis, if patients got randomized into the pre-induction volume, they will include the entire space as shown here.
And if they got randomized into the post-induction arm, then they will treat residual lymph node only. So this table summarizes their volume between the two groups. It's really worth to mention that even the post-induction arm, they will still going to cover the entire pre-induction chemo volume to a 60 to 62 gray, whether this is a primary tumor or lymph node as well. So their primary endpoint is the local regional relapse-free survival. They define it as the time from randomization to documented local or regional relapse or death from any cause. And they have numerous other secondary points like overall survival, distant metastasis-free survival, failure-free survival, toxicity, and quality of life. So they calculated their sample size, and they would like to detect 8% difference in local regional relapse-free survival at 3 years, with 80% power and 5% one-sided type 1 error rate, when they expected 5% dropout, and then their sample size being calculated to be 435 patients. And this is the diagram of the flow of the study. So 225 patients got randomized into the post-induction chemo arm compared to 220 randomized into the conventional or the pre-induction chemo arm. And they'll have a little bit of drop out on each arm. And they did intention to treat type of analysis. So here's the baseline characteristics. And we can see it seems well balanced between the two arms. And we can see it is really locally advanced cohort of patients because almost 90% they are T3 or T4, and almost 2/3 are N2 or N3 disease status. And what they confirm as what we expect that with the post-induction chemo arm, you expect the GTV volume going to be shrinkage. And here the mean shrinkage was 17%. And also there will be a lower dose of the organ at risk like ears and parotid gland. Their primary endpoint, the local regional relapse-free survival, were similar between the two arms. The only difference was less than 1%, actual 0.3%, and not statistically significant. And there is no difference in the other measurable outcome, distant metastasis-free survival, failure-free survival, and overall survival. And they did subgroup analysis. There is no significant difference for the local regional relapse-free survival. The luckily things is that when you reduce your volume, there was significant reduction in acute and late toxicity, specifically the mucositis, dry mouth, weight loss, as well as temporal lobe injury. And the gain is that when you reduce your volume as well, there will be significant improvement in overall quality of life, better global health status, physical and emotional status, and lower dry mouth and lower sticky saliva symptom burden. So the take-home message that local advanced nasopharyngeal cancer responded to the induction chemotherapy can be safely treated with reduced volume radiotherapy. You will have a non-inferior local regional control and survival, but you will gain less toxicity and better quality of life. Our trial support that they can reduce the radiotherapy volume, and this will be a valid options to treat these patients. With that, I would like to thank you for your time and for your listening.
Our next speaker is Dr. Ibrahim Rotain. He's Chairman Radiation Oncology in the King Fahd Specialist Hospital in Dammam. And he's active member of Saudi Assembly of Radiation Oncology. So he will talk us through. He will talk through the
acupuncture of chemoradiotherapy-related dysphagia in patient with head and neck squamous cell carcinoma, a randomized phase 2 study.
Assalamu alaikum, everyone. Thank you for the nice introduction. I'll be today presenting this abstract, acupuncture for chemoradiotherapy related dysphagia in patients with head and neck squamous cell carcinoma. This is a phase 2 trial. And these are the disclosures of the speaker. As a background, we all know that although radiotherapy is a cornerstone in the management for head and neck cancers, we all know that this treatment is related to many side effects, serious side effects that might affect the patient quality of life. Specifically, dysphagia is one of the unfortunately common problem that we face, and it affects directly the nutrition, hydration, and the general status of our patients. On the other hand, acupuncture was tested in many small trials and showed that it has some effect, beneficial effect on some of the radiation-related symptoms, specifically xerostomia. It was tested in one study with the main outcome of dysphagia, but it was negative. For this purpose, this study was designed as a multi-center open-label randomized phase 2 trial, taking patients with squamous cell carcinoma of the head and neck of the oropharynx, larynx, hypopharynx, and nasopharynx. All patients should be a candidate of curative intent radiotherapy plus or minus chemotherapy, and will be randomized into two arms: the standard of care, which is IMRT radiotherapy plus or minus chemo, versus the standard of arm plus acupuncture. The acupuncture arm, these patients will have a 30 minutes weekly session of acupuncture given in certain places as per the traditional Chinese medicine. And they will have this over a total of 11 weeks, 2 weeks prior to treatment, then within the treatment, then 2 weeks after the treatment. The primary endpoint of the study was the severity of acute dysphagia according to the MD Anderson Dysphagia Inventory Composite Score at 2 weeks. And the secondary endpoints, just to clarify, the severity of MD Anderson Dysphagia Inventory to be meaningful, we have to have a difference of 10 points. This is how it was defined. The secondary one included the global score on sub-scale scores, the quality of life according to the RTC scores, acute toxicity, and the feasibility of the acupuncture during radiotherapy. These are the baseline characteristics for the patient itself. Total of 90. They recorded 91 and one dropout, ended up by having 90 patients divided in the two groups. The majority of patients, as expected, were patients with oropharynx, and the majority of those oropharynx patients were patients having HPV positive patients. The stage of disease were actually divided in both arms of the study. We have patients of stage 1 and 2 and good number of stage 3 and 4. Most patients had the standard radiotherapy plus cisplatin. And if we talk about the compliance, although it wasn't shown here in the slides, it was clearly written in the written abstract. The compliance to acupuncture was very, very good, and there was no reported toxicity to acupuncture. Toxicity, if we take the grade 2 or more toxicity, according to the CTC version 5, no difference. Going to the primary endpoint, which is the MD Anderson composite score at 2 weeks, no difference. However, one of the secondary endpoints was the MD Anderson global score. And at 2 weeks, there was some difference between acupuncture versus the standard of care, and also on quality of life there was some difference in favor, both in favor of acupuncture. So in summary, they mentioned that the 11-week course of acupuncture during and around radiotherapy is feasible and safe. However, acupuncture didn't lead to meaningful change in the mean MD Anderson dysphagia inventory composite score, which is the main, the primary outcome. Acupuncture instead was associated with better outcomes in the MD Anderson dysphagia inventory global score, health-related quality of life. And hence, further studies are needed, definitely to confirm the results and to show us if these results are really clinically relevant. These are the acknowledgements, and I thank you all for listening.
Thanks very much, everyone. Great presentations. Any questions from the audience? I can start, then we'll go from there. So, question for you, Muhammad.
I would like to ask you.
Putting you in the spot first. So, did you guys change the standard practice for nasopharynx after this study or at your institution?
Well, I was exactly planning to ask you the same question, Ali.
Smart.
The data is clear, huh? It's a phase 3 non-inferiority, well designed, and they ask valid questions. They did intention to treat analysis. However, in my center and myself, I'm not feel yet comfortable to change my pre-induction chemo volume, because the classic teaching is that the nasopharyngeal cancer is seen to be infiltrative, submucosal disease. So there is concern that there might be a disease there that you might miss if you reduce your volume. I love to hear Dr. Ahmed Bouchehri opinion about this, you, Dr. Ali, and Dr. Isa as well, and Dr. Ibrahim.
Okay, so we unfortunately started it at our institution, but with a little bit modified version. It's unfortunate because the amount of work is too much. You're actually contouring 2 cases of nasopharynx in one, and definitely with non-reimbursement, that forget about physicians, but at the institution level, it's a lot of work. So we do 2 MR-SAM, 2 CT-SAM, we do double contours for the GTV at least. We pre-chemo, MR, SAM, and CT-SAM with a mask, then post-chemo, MR, SAM, and CT-SAM, and we have an institutional protocol for this right now, so specific weeks at each time. But we did a little bit minor modification because we worry about the original GTV. We don't know if the shrinkage of the tumor is an ice melting or it is a balloon deflation. We are not a believer in balloon deflation after chemotherapy for any cancer, or after radiation even for any cancer. So we keep the pre-chemo GTV to receive the full dose of 70, but not taking a CTV beyond it. So we'll contour the post-chemo GTV at 2 to 3 millimeter margin. Most so probably it ends up that it includes the whole GTV prior to chemotherapy. If not, we make sure it's within the CTV 70. That's the only modification with that. But it's very compelling. And the difference, yeah, this one is results was, I didn't expect it will show this way, honestly. It's published, yeah.
Expected and it's published.
Yeah,
as
it's
well.
published.
I'd love to hear Isa opinion, Dr. Isa.
Yeah, actually, I implemented this protocol a few years ago at KHCC. So for post-induction volumes, I do the same as Ali mentioned. But it's time consuming actually. So one post-induction case takes time longer than definitive treatment in doubling time or even more. So pre-induction volume, I do treat to 63, post-induction volume to 70 gray, but I make sure that the post-induction volume CTV is containing the areas that infiltrated initially by the gross disease. In some situations, we are struggling when we have some lymph nodes in the neck that completely disappeared after induction chemotherapy. Still, I treat these areas to 63 gray. Also, I chase the areas or the regions of infiltrated by extracapsular extension to pre-induction to in the CTV volume. So this is my current practice at KHCC.
Yeah. So I didn't understand, but for cavernous sinus invasion, Ali, so they said in case of response, they will do partial cavernous sinus treatment or they'll do full cavernous sinus. What do you do, Ali, for cavernous sinus?
Okay, so in reality, if you have a GTV and cavernous sinus, you will never be able to put 70 gray. So, and we know that the pre-chemo GTV will get 63, so we put a 63. I can see big dosimetric difference, honestly. So if there is a response, actually, in reality, that's the most probably helpful for the patient, for us, because now we are only giving 63 instead of giving 70 gray. Let's listen to Ahmed.
We still, same as Mohammed would said, we are still not confident to go with the post-chemo volume, but we started a few cases. I thought we are doing it ourselves, but I think it's taking the pre-chemo volume and not adding a CTP on it. I think this is a good way to do it.
So one comment. First, it's so difficult to define the GTV on MRI post-chemo. It's very, very difficult. Like the presented case, the prevertebral space infiltration and MRI, it's not easy to define, even with PET scan, because you never know whether it's only metabolic or real complete response. So this is one thing. Second, how I do it, I do modified GTV. For example, anything what we call it, the ballooning like response. Anything in the air, I crop it. Anything even going to the, for example, the pterygoid palate, like the example shown here, I also crop it. And I'll make sure that the volume, initial volume, will take full dose. Lymph nodes, if it's not there, it's not there. خلاص. Lymph nodes, if it disappeared, it disappeared. I give it a lower dose. I don't give it an intermediate dose. But anything that was avid on pre-chemo, even if it's much smaller and it's non-avid, I'll still give it 70 gray.
Questions from the audience? Yes, Dr. Amr.
Having the same theme of volume reduction, do you ever try to spare like lower neck nodes uninvolved with side of the neck?
For nasopharynx, yes.
Nasopharynx.
Also, there is a randomized control trial published from our colleagues in China, and patient with no nodal involvement on one side, we don't treat level 1B right now, and we don't treat lower neck. Again, that's problem in head and neck radiation oncologists. They are very meticulous, so they don't want to change. So it's like I'm one of them, very old school. So when we try to change that at our institutional policy, I was raising my hand. Okay, can we do a modification? So for example, I suggested if we have a level 1, 2A involvement, then please include level 1B, but should be anterior close to submandibular gland. If you have multiple nodal disease at level 2 and 3, include 1B. If you have nodal involvement at level 3, don't spare level 5 and 4B down. And again, it comes with our like background that we don't want to change it. In my opinion, in general, I am okay with the volume de-escalation rather than dose de-escalation, because dose de-escalation has failed, and we know that. And as you always say, don't go to the desert without knowing there is an oasis or not. تروحش للصحراء وانت مش عارف ما عندكش ميه ولا لا. It doesn't make any sense. So you minimize the dose, and the previous de-escalation dose for head and neck failed. An example for the trial that Dr. Isa just presented, the US went there and used Nivo based on basket trial, and they didn't go to phase 2. They just moved to phase 2, 3 design to prove that immunotherapy is going to work well with radiation treatment. And they didn't fully understand the radiobiological principle beyond that. And we were shooting our feet, expecting that we're going to improve the outcomes, and the outcomes went down. So that's why I'm okay with volume escalation for the elective target, but not for the dose escalation in general.
Thank you for this very important topics, choosing them. My question is in the same trial, Dr. Mohammed. What did they mention in that trial about intracranial extension? Like in our region, we see patients with very frequently with a huge, massive intracranial extension.
Yeah, the same as what they mentioned about the cavernous sinus. They said that there is response, they will do partial coverage of that. And there is no response, they will take it full. And with induction chemo, I notice that usually with induction chemo, you will have a good response extracranial, but little or maybe no good response to the intracranial. So a lot of times you ended up doing the full dose coverage if feasible. What do you think, Dr. Ali?
We have the same problem. I came from an institution back in Egypt when we had a big delay in the radiation treatment machines. And during my residency for like 3 or 4 years, in addition to other 2 years, we were using induction chemo in 2007 because we just delayed. And like probably I treated more than 200 or 300 patients this way. Out of context just to start the patient in treatment, and we were struggling the same. Then when I knew about the trial, okay, it's not going to be very helpful on the I wish they asked me.
I am not sure, Dr. Muhammad, if they had excellent quality assurance for radiation therapy plans.
In their paper, they mentioned they have a good quality assurance. That's what they mentioned, but who knows?
Because I don't think that the radiation oncologist will strictly follow the guidelines in post-induction versus pre-induction target volumes. It's really so the internal feeling, it's always toward increasing the volumes even in the post-induction setting. So I think quality assurance is crucial in this trial.
So that was raised actually, and they were asked to publish it. They said they have a quality assurance. They were asked, but hopefully we can see it. So should we conclude? Yeah, thanks very much, everyone, for listening.
Thank you.
This will conclude our day today. Inshallah, tomorrow we will meet at 8:30 in the morning. For the best of Astro, will be here. And for the SARO, will be on the next hall 1, inshallah. Can we take a photo together? Is it okay? We need to take a photo.